Hello. A very good morning and a warm welcome to one and all. Roginam pranarakshane cha vaidyo dharma prasadakah. Roginam pranarakshane cha vaidyo dharma prasadakah. The physician who saves the lives of patients fulfills the highest duty. This indeed is immensely applicable to obstetricians as we are constantly shouldering the responsibility of two lives at the same time. In spite of many advances, obstetric hemorrhage still remains a leading cause of maternal mortality worldwide. Every moment lost in recognizing and treating obstetric hemorrhage increases the risk of severe maternal and fetal morbidity and mortality. It's a stark reminder of fragility of life during childbirth and underscores the paramount importance of preparedness, vigilance, and skilled intervention. So, without any further ado, let us begin with our first session. I would like to invite Dr. Nanda Magai Madam and Dr. Anjali Jamma Madam to chair the first session. Dr. Nanda Magai Madam is practicing consultant obstetrician and gynecologist in Solapur since past 28 years. She has been president of Solapur OBGYN Society in 2019-20. She is a recipient of Foxy Rotating President Trophy. She has taken special training in cosmetic gynecology from Mumbai and Mohali. Dr. Anjali Jamma Madam is a consultant at Jamma Hospital and Laparoscopic Surgery Center since 2000. She is a pioneer of cosmetic gynecology in Solapur. She was president of Solapur OBGYN Society in the year 2022-23. She was organizing secretary for 2 zonal conferences. She is invited as faculty for state and national conferences as a cosmetic gynecologist. She has also conducted many public awareness programs on teenage problems. Over to you, chairpersons.
Thank you, Amruta, for the kind words. Today, Dr. Neeta Ghate and her team have arranged the CME in obstetric hemorrhage, a nightmare of an obstetrician. We have eminent faculties in this session. The first talk will be by Dr. Megha Pekam. She has graduated MBBS from Sri Vasantrao Naik Government Medical College, Yavatmal, and she has done post-graduation, that is in radiology from Vision Diagnostics, Vivekanand Hospital and Research Center, Latur. She has done fellowship in advanced OBGYN ultrasound at Fetal Medicine Department, VS Government Medical College and SVP Hospital, Ahmedabad. And she will be talking on understanding imaging in placenta previa and morbidly adherent placenta. Over to you, Dr. Megha.
Good morning, one and all. First of all, I will thank organizer Dr. Ghate ma'am and whole OBGYN team for giving me such opportunity to present a topic of sonological diagnosis of placenta previa and morbid adherent placenta. First of all, we will see embryology and placental development, normal placenta and ultrasound evaluation, and placental abnormalities. We can see this is 4.5-week embryo in which we can see fetal pole, amnion, yolk sac and umbilical vessels in umbilical cord. These are chorionic villi, and this is the residua basalis, that is maternal part, which contains maternal blood, and chorionic villi and umbilical cord contains umbilical blood. This is 7-week embryo. We can appreciate amnion, fetals and umbilical cord. These are chorionic villi and cuttage of the chorion. In this image, we can see this is placenta and residua basalis and chorionic villi. On microscopic level, we can appreciate this is myometrium. This is stratum basalis of the endometrium, very thin layer. This is maternal portion of the placenta that is called as residua basalis, which contains maternal veins and arteries. And this is the fetal portion of the placenta, which contains fetal arteries and venules. This is also called as chorion. This is transabdominal ultrasound axial scan, which shows Hyperechoic placenta, which contains vascularity on color Doppler imaging. This is cord insertion site, this is umbilical cord, and this one is hypoechoic myometrium or retroplacental space. Here we can really appreciate the hypoechoic myometrium. This hyperechoic is placenta and subplacental clear space, which is also called. Placental abnormalities, we will see one by one. Placenta previa, placenta accreta, abruptio placenta, placental infarction, placental masses, and morphologic abnormality. So placenta previa, the previa term itself shows that it is presenting before or going before. Previously, the obstetricians used to do per vaginal examination, and instead of fetal head or fetal parts, they used to feel the placenta. That's why the term is derived, placenta previa. By definition, implantation of the placenta in lower uterine segment. In this image, we can see the placenta is developed in the fundic region, which is most common site because of the hypervascularization of the fundic region. Incidence is 0.5%, bleeding is hallmark sign. Accurate diagnosis is vital, but not before 15 weeks. Transabdominal scan is ultrasound is most of the time preferred. If unclear, we can use the transvaginal ultrasound. There are 4 degrees of the placenta previa. First degree, type 1, placenta previa lateralis or low-lying placenta. The lower edge of placenta reaches the lower uterine segment but not internal os. In this image, we can see the placenta is implanted in lower uterine segment, but the lower edge is not reaching the internal os. Second degree or type 2 is placenta previa marginalis. The lower edge of placenta reaches the margin of the internal os but does not cover. Here lower edge is reaching the internal os, but it is not covering the internal os. Third degree or type 3 is placenta previa incomplete centralis. Placenta covers part of the cervical os. The placenta covers internal os when it is closed or partially dilated, but not when it is fully dilated. Type 4 is placenta previa complete centralis. Placenta completely covers the internal os even when cervix is dilated. Placenta covers the internal os completely, whether cervix is partially or fully dilated. In this image, we can appreciate placenta is completely covering the internal os. On ultrasound imaging, this is transvaginal sagittal section. This is hyperechoic placenta. This is endocervical canal, and this is internal os. The placenta is completely covering internal os. So this is complete placenta previa. On MRI imaging, we can appreciate this is endocervical canal, this is internal os, and this hyper intense is placenta. Marginal placenta. In this image, we can see this is bladder, this is myometrium, bladder uterine interface, this is placenta, and this is endocervical canal. So lower edge is reaching the internal os, but not covering internal os. This is a transabdominal image on sagittal section. We can see this is amniotic fluid, this is hyperechoic placenta, and this is endocervical canal. So internal os is within 2 cm, that is low-lying placenta. Placenta accreta, but according to Society of Fetal Medicine and AICOG, the new classification has been invented in placenta previa. The 2 classes are there only, placenta previa and low-lying placenta. Irrespective of the lower edge covering internal os, or it is within reaching the internal os or covering internal os, it is only called as placenta previa. And if it is within 2 cm from the internal os, it is called as low-lying placenta. So placenta accreta. By definition, chorionic villi attached to myometrium and villi invade past maternal residua. In this image, we can appreciate normal decidua and stratum basalis of the endometrium, very thin layer, and this is the placenta and this is cord insertion. So there are 3 types, accreta, increta and percreta. Accreta, in which the placenta attaches to myometrium but does not invade the myometrium. Accreta is most common type. In this image, we can see the stratum basalis of the endometrium is invaded, but not myometrium. Increta is the second most common, in which the placenta invades the decidual stratum basalis of the endometrium and some part of the myometrium. Here we can appreciate the myometrium is also invaded, and percreta invades the past uterine serosa into organs. In this third type, which is very less common but life-threatening, the percreta has invaded the stratum basalis, the myometrium and serosa of the uterus. Risk factors: prior uterine surgery, placenta previa, unexplained elevated AFP levels, advancing maternal age. Clinical manifestations include profuse hemorrhage after delivery, which is very challenging and life-threatening condition, inability to separate placenta from uterus. On sonographic findings, coexisting placenta previa, adherent portion low in uterus, loss of normal hypoechoic retroplacental myometrial interface, thinning or disruption of the hyperechoic subvesicular uterine serosa, presence of focal exopathic masses, numerous placental legs. In this transabdominal axial image, we can see this is fetal head, this is lower uterine segment, and placenta is implanted in lower uterine segment. There is loss of hypoechoic retroplacental clear space. On color Doppler imaging, there is diffuse lacunar blood flow, dilated vascular channels, absence of normal subplacental venous flow, demonstration of vessels crossing placental myometrial disruption site. On transvaginal ultrasound, we can see this is bladder and this is uterine bladder interface, and the thinning of the hypoechoic myometrial interface is noted, which is replaced by vascular channels. Longitudinal ultrasound shows an anteriorly lying placenta completely covering the internal os. This is bladder, urinary bladder. This is uterine bladder interface. And this hyperechoic placenta is implanted in lower uterine segment. This is previous scar site. This is endocervical canal. There is loss of clear retroplacental space near the scar site. Here we can appreciate this in this area the retroplacental clear space is lost. Further lacunes extend into the uterus bladder interface and show abnormal color filling. On color Doppler imaging, we can see this hypoechoic region is showing vascularity. That is the lacunae which show abnormal color filling. Above mentioned findings were likely suggestive of adherent placenta. So multiple placental abnormalities can be detected on prenatal sonography. Basic anatomy and physiology of the placenta should be understood so that abnormal findings can be acknowledged to achieve best possible outcome for mother and baby. These are my references. I will be happy to answer questions if any.
Any questions?
Thank you.
Thank you, Dr. Megha, for the lucid presentation. The images were also very beautiful.
I request our President, Dr. Ghate Madam, to felicitate Dr. Megha Begum.
We move on to another important talk by Dr. Kasturi Donimat. She is a great academician and has huge list of achievements and has adorned important posts. She is from my alma mater, KIMS Hubli. I am so proud of her. Welcome to Solapur, madam. She is immediate past President Kasoga, President Kasoga 2022, Professor and HOD Department of Obstetrics, KIMS Hubli, ex-President HDOGS, ex-Secretary General HDOGS, Principal Investigator for International Research Projects, MCI Inspector to colleges all over India, UG and PG examiner.
It's okay, I think so. No, no, madam.
Yes, ma'am. Just
No, 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 ma'am.
it takes so much, lots of.
No, madam. Okay. A pleasant morning to one and all. I'm really very happy to be in Solapur today. And first of all, immense thanks to Neeta for inviting me for this CME, and Amruta, and all the chairpersons for a nice introduction. And she's from our own college, 86 batch. And I feel very proud to be in this here, especially today, because I was able to meet Sir Desai Madam. Madam, it was my dream come true to meet you. I had heard so much about you. Doctor, I had heard so much about you, and we are following Sir Desai regimen, and Dr. Ramalingappa followed, and he brought into practice whatever you had taught here. And actually, whole KIMS is want to see you once. So thank you, madam, for being there. I feel little apprehensive to talk in front of madam, such senior madam. And my pranams to all the seniors here. And today I'll be talking on management of placenta accreta. See, this uterus none of us want to see. It's a real nightmare. Yes? We don't want to see these cases. So though it is a very rare condition, it's a big, big nightmare to all the obstetricians. On one side, it's a very dreaded complication. On the other side, there is really paucity of information. There is no trials or the RCTs on this, because these are just anecdotal cases here and but nowadays it's no more an anecdotal. We are seeing lots and lots of cases of placenta accreta. I think lots of studies and way of management information should come into the literature. So all these placenta accreta, increta, percreta, we know placenta accreta 75 to 78% of the cases, and percreta 5% of the past disorders. That was depending upon the invasion into the myometrium, that's classification. But this classification is dependent on whether the whole placenta is invading, that is total, only a part of it, but it should be more than one cotyledon, then it is partial placenta accreta. Only a small part of a cotyledon or a single cotyledon is invading, then that is focal placenta accreta. This is very important to know, because our way of management can differ depending upon whether it is total, partial, or focal. One more is clinical grading. When we see on the table or intra, just mildly adherent, not this thing, that can be removed. But abnormal adherent, where MRQ can be done, that is, doesn't come under past disorders. But once it starts invading the myometrium, whether it is only part of the myometrium, whether it has gone up to the serosa, whether it was involved the bladder, or whether it was involved the parametrium, ureter, rectum. So all this clinical grading is extremely important to manage. There is one more classification, that is American ICD coding. They do depending upon whether it is in the first trimester, second trimester, third trimester. So these ICD codes are there depending upon the trimesters. This is very new classification. And now what are the risk factors? Risk factors, as per the evidence from control studies, consistent risk factors, known risk factors are placenta previa. Low-lying placenta is a very high risk factor. Previous section is very much known factor. Consistent data is available that it is a very high risk factor, consistent. That too, more than one section, 1, 2, 3, the incidence increases. Then even IVF and ICSI. It is shown that ART procedures does have a risk, though in an unscarred uterus, because they alter the endometrial milieu, the decidualization. So the endometrial, especially the studies have shown that in ART procedure, it is more with the cryopreserved embryo transfer. That is frozen embryo transfer, the risk of placenta accreta is more common compared to the fresh embryo, this one. So what happens there is, when you transfer the cryopreserved embryos, the endometrium is thin because they have given GnRH analogs and all prior. So endometrium is thin there. Or the estrogen or in circulating is also thin. That affects the decidualization. So IVF, especially with the frozen transfer, we should be careful. We should be on a lookout for this placenta accreta. Then evidences have shown, but inconsistent are prior myomectomy, prior septum resection, or any other uterine surgery. See, any surgery on the uterus which affects the endomyometrial milieu or has any scar there is a risk factor for placenta accreta. Even previous uterine curettage, if you have curated very badly, if it has damaged the endometrium, then the deciduration. Then advanced maternal age. Chronic smoker, yes, we cannot just take it lightly. In chronic smoker, what happens is the estrogen is less in them because the smoking affects the conversion of the androgen into estrogen. That part is affected, and then circulating estrogen is less, as a chronic smoker is much prone for this. That we have to, this awareness we have to spread in the public. Though it is not much common in India, it is there in Western countries. The evidence is from anecdotal case studies, which is not very much consistent here. Previous history of if there is a past disorder, she can have. If you have done TCRU or endometrial ablation, or if she has undergone radiotherapy, or past history of uterine embolization either for leiomyoma or adenomyosis, and congenital Mullerian anomalies involving like septate uterus, rudimentary horn. Yes, in rudimentary horn, because the myometrium is thin and even the decidualization is improper there, again there can be a placenta accreta. Especially adenomyosis, there is lots of studies or literature available in adenomyosis is what happens if a focal adenomyosis has been resected and this thing, those cases are much more prone. One is because of the scar, another is more than myoma, adenomyosis rejection is more prone for placenta accreta. One more thing is, these adenomyosis cases, we are putting them on long-term GnRH agonists, so that suppression, again that affects the decidualization. So adenomyosis cases, especially when you have done resection, we should look out for placenta accreta when they become pregnant. So it's not just that women having scarred uterus, unscarred uterus also, because what I told you, they can be having risk for placenta accreta spectrum. So at the end, anything that has damaged the endometrium, any procedure, even uterine artery embolization because of the blood supply, can be a cause for past disorder. I told you, after 1 LSAS, the risk is 11%. 40% immediately after 2 LSAS, the risk jumps to 40%, and after 3 LSAS, it jumps to 61%. One more very important risk factor, which I just want to speak towards, is cesarean scar pregnancy, CSP, cesarean scar. It's a definite risk factor for PAS. So it's very, very important that we detect cesarean scar pregnancy in 5 to 7 weeks of gestation only by transvaginal scar is extremely important. If you miss this cesarean scar pregnancy in the early gestation, this can present, many women in between, they don't come only for antenatal checkup, they can directly land up as placenta accreta. And if you detect them at 5 to 7 weeks, we should counsel the woman that it is better and safer to manage this CSP in the first trimester itself. Because some people want to wait. Just now we'll wait for another few weeks and all. But more the gestational age, more complicated it is to manage the cesarean scar pregnancy. Earlier you diagnose, it is easier and safer to manage cesarean scar pregnancy. So you should convince them that it's better and safer for the patient, not only now, in further. Surgical management is extremely safe, even better than medical management, because when you are done medical management, some amount of niche may remain there, and that can be again a cause for next. But surgical management, you are completely removed, and you can do fertility preservation and less recurrence risk compared to the medical management. So in case if you are not detected or the patient is not willing for any treatment, she tells, I don't have any bleeding, anything, I want to continue the pregnancy. If she continues, she can have a viable baby, but at the cost of the life, at the cost of the morbidity and mortality of the woman, and she'll have to sacrifice her uterus because she has continued this pregnancy to become a placenta accreta spectrum. So it's extremely, extremely important to detect cesarean scar pregnancy at the earliest. So if you have a previous section, any case previous section when she becomes pregnant, make it mandatory to do an early pregnancy scan with transvaginal sonography so that you don't miss cesarean scar pregnancy. And earlier you diagnose, best you can manage. So pathophysiology of placenta accreta spectrum is, as you know, decidualization is very important for a normal pregnancy. So any interruption in the endometrial integrity, the invasion of the trophoblast goes beyond the junctional zone because it wants the space there and leads to, it goes and adheres to the, it goes into the myometrium, again much more it goes, and then it affects the vasculature. This is the result. This is because of the neoangiogenesis, haphazard neovascularization, this is, and dilated, even radial arteries, arcuate arteries, everything is dilated. So this is, so we don't want to see such pictures because of placenta accreta. So you can see the width of the arcuate artery in a normal side and when a placenta accreta is there. So all the complications, why we are so much afraid of this placenta accreta? It's because of the heavy bleeding. And why there is heavy hemorrhage? Because of the alteration in the vascularization, neovascularization, and this neovascularization is thin-walled and it is very haphazard, where you don't, the total anomalous, the aberrant vascularization. So that is what causing all the morbidity and mortality of the woman. So this is the culprit, vascularization. Now, clinical significance, why it is important? As I told you, life-threatening massive hemorrhage, associated with lots of bladder injuries, ureteric injuries, if early cases, rupture and perforation, and most of them land up in peripartum hysterectomy, very few conservative line, and associated with high maternal mortality. Yes, in the past, the diagnosis was only at the time of delivery. When we were there, when we didn't have ultrasound, I have been finished post-graduation when there was no ultrasound. So those days, placenta accreta spectrum was diagnosed only after delivery. So after delivery, with heavy bleeding, when the woman comes, we used to try to remove the placenta, but it wouldn't come. Then they shift the patient to OT, but at that time, so much she would have bled, it would almost lead to maternal mortality. But now these days are not so. We can antenatally diagnose them. So you have high index of suspicion in all the risk factors I have told. If you have high index, and when you tell your radiologist, if it is a previous section, placenta previa, send once again back to the radiologist, tell him, I want placenta accreta to be ruled out, adherent placenta spectrum to be ruled out. If you have any previous scar, myomectomy or anything, just alert them, tell them, you can ask them, call them and tell, please rule out. So because of the technology, good this thing, now we are able to detect antenatally, not like the past when we used to see the patient in a very bad condition. Our diagnosis in those days was only histopathological diagnosis. After we have removed the uterus, when we used to send it to the pathology department, they used to tell that placenta is invading. Yes, madam agrees, I think. Those days it was so. Yes. Now ultrasound. Madam, Dr. Megha has already talked about ultrasound, so I will not go into the details. But it's mainly the presence of lacunae. Most important is loss of the translucent zone and thinning and disruption of the uterine serosa and bladder interface. Dark intraplacental bands will be there and highly vascular. Because I will not go into these details of ultrasound findings. Color Doppler is extremely, extremely important because there will be markedly dilated vessels, high velocity venous type of flow, and usually we don't see so much vascularity in the bladder and uterine interface, but here highly vascular bladder and uterine interface you will be seeing here. Yes. You can see in this picture. And 3D ultrasound is also very important. It plays a very important role in this because it has high predictive value and high sensitivity, high specificity. So it's the single most reliable diagnostic modality. Increased tortuous vascularity, chaotic branching, hypervascularity, all this can be detected by 3D ultrasound. MRI, it's very useful, especially in obese patients, especially when the placenta accreta is in the posterior. It's much better, you should go for MRI if it is in the posterior wall or in very obese patient. And one more is oligohydramnios. And one more important thing is, if it has invaded the bladder and if you are suspecting that it is invading the parametrial tissues, you want to know the topography. You want to know to what extent it is involving the parametrium and what kind of surgery you have to plan. MRI is extremely useful. So these are MRI images. So some tips for ultrasound and MRI diagnosis is, if you are doing transabdominal scan, we have to do with full bladder, so that the bladder outline is clear in relation to the lower uterine segment. Because if you have empty bladder, that interface, the placental bulge, the hyperoscopy is difficult to pick up. So you should do transabdominal with a full bladder. And it's not just putting a probe there. You should walk on the placenta. You should walk on the implanted scar. Keep the transducer perpendicular on the uterine surface. Move the transducer from above down, from one end to other end, side to side, above down. Why this is important is, you will not miss what I was talking about, partial and focal. If you don't walk on the placenta from above down and from side to side, you will miss those focal placenta accreta or partial placenta accreta. And if you miss that, especially those cases, you will really land up in trouble, more than the complete. I'll tell you why. Because there half the placenta separates, patient is profusely bleeding, and you have not diagnosed it. You feel it's not there. Then you try to do some manipulation, patient by the time goes into pulseless, BPLess. So walking on the placenta from side to is extremely important to detect those cases. Even if you are doing transvaginal scan, you should do with full bladder to know the uterine bladder interface. Because otherwise, when we are doing transvaginal, we ask them to empty the bladder and come. But here you have to do with full bladder. And when you are putting the probe, don't put too much pressure. Otherwise, you will increase your diagnosis of placenta. That's false positive you will give diagnosis. And 3D power Doppler is very, very excellent, important to diagnose. And MRI, especially good, as I told you, to know the topography, the area of invasion. But one important take-home message in MRI is, you tell your radiologist not to use contrast. Why? Why not to use contrast? Because contrast has a bad effect on the fetus. Because contrast is secreted, it enters the blood circulation, preterplacental circulation, and the fetal kidney excretes this contrast into the amniotic fluid. So the fetal kidneys can be affected, and also it can cause long-term inflammatory disorders in the fetus. Though not direct abnormalities, but it can cause long-term inflammatory disorders, and also it can affect the fetal kidneys. So not to use contrast when you are doing MRI. Otherwise, MRI is safe. Earlier days, we were a little afraid of MRI also, because we used to think if you do MRI, that fetus will get heated or something, but that is ruled out. But contrast you should not use. MRI is safe, but contrast we should not use when we are doing MRI. And we don't need, with just MRI, we can know the topography. So MRI, how it helps in management. See, if it is sector 1 invasion, we can plan the surgery. We can just do hysterectomy if it's sector 1, simple. Then we can proximal vascular control by uterine or intra-iliac ligation or compression sutures. Ureteric stenting is not necessary. But if it is sector 2, section 2 means it's involved into the totally up to this thing. There, along with hysterectomy, etc., ureteric stenting is advisable. But when it has involved the parametrium, along with hysterectomy, all this intra-iliac, etc., mandatory ureteric stenting is there. Otherwise, you will injure the ureter. If you are not stented and identify the ureter, you will injure. So the MRI helps us where we have to do ureteric stenting, what kind of surgery we have to choose. And if MRI tells that there is cervico-trigonal vascular hyperplasia is there, hysterectomy, here intra-iliac also doesn't. Because if you try to go near the intra-iliac, it's highly, highly vascular. You are going to injure this neovasculars and it's going to bleed like that. So in those cases, aortic compression or aortic clamp or common iliac clamp will help more than the intra-iliac. So if it is so much vascular, so MRI is so very useful. You can plan prior and you can plan whom to have. We can have a vascular surgeon, we can have a urologist with us before we start the surgery when all this. When it's just simple case, we need not call them. But MRI helps us, which all team we have to include, and what surgery has to be planned, we can plan before only, not after opening. So it's extremely important, MRI topography. Biochemical markers, it's more of theoretical, increase alpha fetoprotein, or increase creatine kinase, or increase fetal cells in the maternal cell, even that is ruled out now. fetal cells in the maternal, that which we do NIPT like that, but it's not much increased. So all these are in the research level, not very useful in our day-to-day diagnosis. So screening for placenta accreta should start right from, if it is a previous section and all, right from 5 to 7 weeks. In other cases, from 20 weeks at least, you should know, not at the time of delivery. Management, it's a multidisciplinary approach. Delivery should be conducted in a Center of Excellence hospital, well-equipped hospital that we call COE, Center of Excellence Hospital, not in the periphery, not when a single person is practicing, not in a small nursing home, a single alone practice. It should be a teamwork. And early detection during INC is a must. In case of antenatal detected cases, you should involve a senior obstetrician who has done these cases previously, many more, senior anesthetist, urologist, interventional urologist, neonatologist, and vascular surgeon. All this should be in your team. Then only you can do justice to the patient. If everybody is not into your team, if you end up in complication, you are not doing justice to the patient. And most important is counseling and taking consent. Counseling is very, very extremely important, not just to the patient, more than the patient, all her attenders, her husband, all the attenders who are going to be there with her at home and at the time of delivery should be counseled very well. And you have to do counseling for all this and also consent. Whatever I am telling, it is both for counseling and a written consent. So counseling for need of hysterectomy and consent taken, consent for massive transfusion, consent that we are going to hold a multidisciplinary team, need of ICU admission, prolonged admission, NICU admission for the baby, risk of bladder injury, other organ injury, other interventional procedures, that also has to be consent and counseling has to be taken. Consent for massive blood transfusion and the problems due to massive blood transfusion and emergency, and even the on-death table has to be explained and consent has to be taken. So management of antenatal diagnosed cases is, one is counseling, and if she is just in a 27, 28 or 20 weeks, you should tell her refrain from sexual intercourse. Attenders should be told that she should never be left unattended at home. Somebody has to be there with her at home. She cannot leave her. Suddenly she can start bleeding and land up in problem. And she should have, or the attenders should have, the phone numbers of the hospital or the point of care at hospital and the doctors, and also ambulance numbers she should have. Sometimes the way they come, only if they have all this practically, then they can reach the hospital safely. Otherwise, they'll come in a very bad state. And they should be sensitized about early symptoms which can lead to heavy bleeding. Like if they have any vaginal discharge, or if they have any abdominal pain, if they have any little spotting vagina, little hematuria, they should rush to the hospital. They should call for an ambulance and rush to the hospital immediately. And later part of the pregnancy, she should be as near to the hospital as possible. She should be in a commuting distance. She cannot be around 50 kilometers from here. By the time she reaches, she'll be back. So she should be in a very near to the hospital. She should see to it that she stays very near to the hospital. If she cannot do that, she can get admitted in the later part of pregnancy. And you should have taken all the consents which I have told, like conservative or hysterectomy, transfusion, etc., has to be taken prior in the antenatal period itself. You should have taken, not when she comes in emergency, you should take when in the antenatal period itself. And good coordination between the multidisciplinary team. I keep telling, you should have a WhatsApp group for that patient with all the specialists, so that if this patient is coming, we need your help, we can at least send a message. That time we cannot go on telling where are you, where are you. So that good coordination is sure. And serial scans has to be done for growth and the invasion for 24 weeks, 28 weeks, 32 weeks, etc. And will you plan a scheduled or unscheduled delivery in placenta accreta? It should be always scheduled delivery. Unscheduled delivery can end up as a catastrophic event. Both fetal death and maternal death can occur, so always plan for a scheduled delivery. And also you should sensitize the patient where they can end up in unscheduled and rush to the hospital. So the predictors for unscheduled delivery is if she has a short cervical length on ultrasound from the beginning, or if she has on and off spotting, if she has on and off contractions, or if it is a twins or PIH, or if she has leak. These are the patients who will end up in unscheduled delivery. So you should be very clear to them, this you can end up in emergency. Otherwise, this thing is always scheduled delivery for placenta accreta. Then only both the mother and the baby and yourself are safe. And timing of delivery, when do you deliver them? So ideally would be after 34 weeks for the sake of the baby. Will you wait after 37 weeks? No. All the countries, all the studies show that you have to deliver between 34 to 36 weeks, 5 days. You should not go beyond 37 weeks because if you wait, she can end up in unscheduled delivery and end up in problems. So between 34 to 36 weeks, 5 days is this thing. But if it is individualized, it depends on her maternal condition, fetal condition, any complication she has, then you can decide accordingly. But it has to be individualized. You cannot go as per the guidelines. It has to be individualized as per the patient, but better to deliver them after 34 weeks. But if she's totally stable, you can wait up to 36 weeks, 5 days. Steroids have to be administered, and even if you have waited, plan for a MRI after 32 weeks just to see the topography, if it is percreta. If it is just accreta, no need. If it is percreta, plan for an MRI at 32 weeks to know the size. So you should have this checklist at 32 weeks itself. OT, anesthesia, what kind of surgery, whether she is for conservative line or for hysterectomy, whether all the team is needed, blood transfusion, whether the blood is ready in the blood bank. All this has to be done at 32 weeks itself. Blood bank information, etc. Now what about conservative line of management? Conservative line of management in very few cases, we had also done in very few cases, but what happens is our patients don't come for follow-up. One patient though, even after 6 months she had, and we had that one camp. So when we went for camp, that time she is telling, she had not come only 3-4 months, then we brought her and did, still placental tissue was there. So we really don't know, though the books tells 6 weeks up to 12 weeks, I've seen up to 6-7 months also the bit of placenta still remaining back. So very, very questionable about conservative line. Like we can give, but depends, we have to explain all the risks. So different conservative line of management approach are expectant line, just leaving the placenta in situ, leaving the placenta, giving methotrexate, leaving the placenta and doing devascularization of the uterus or interventional radiology, leaving the placenta in situ and systemic resection of the retained placental tissue with hysteroscopy, or leaving the placenta in situ and doing high intensity focused ultrasound, or one-step conservative surgery, that removal of accreta area, or triple P procedure. Triple P procedure, I'll just explain you. Conservative line is mainly to retain fertility, but I will tell you, when we have left the placenta there, it has taken 6 to 7 months to do apoptosis and this thing. That area is still prone for next pregnancy past disorder. So that you should tell. We may retain fertility, but again you are prone in the next pregnancy. If she is ready to take that next pregnancy also pass, then you tell her, okay, you can go ahead with conservative line. So at the cost of retaining fertility, we are exposing that patient for a repeat past disorder. So when you leave, and also the complication are, these patients may end up in hysterectomy at the later part. We have left, it goes into necrosis, she goes into sepsis, or she goes into DIC, or it doesn't come out at all. She may end up in one or the other complication. Again, we may have to do hysterectomy to save the mother. So, but when you leave them, you should make it particular that they have to come for regular follow-up. Regular follow-up for ultrasound, for WBC count and CRP count to see to it, and this coagulation disorders, so that whether they end up in infection or DIC. As I told you, 6 weeks or 6 months to 1 year it takes. Some cases have taken 1 year also. And about methotrexate, I am very skeptical, because I feel that methotrexate acts on a very actively multiplying cells. Now when you have left the placenta, here the cells are not actually multiplying, they are actually deteriorating. And how can methotrexate act on these cells? I don't know, though the books give methotrexate as a treatment, I am very skeptical, because it's not actively multiplying cells, how much it's going to act, And at the same time, we are putting the patient at the risk of methotrexate complications, all the complications which we know, and also the baby. She's feeding the baby, so we are putting methotrexate. So when you are giving methotrexate, we have to stop breastfeeding. So 2 things. So think before you give methotrexate whether it is ideally needed. I have not seen with methotrexate nicely going off and all. Okay, we had put in some cases, but we didn't see much apoptosis with that. So complications of methotrexate, sepsis, necrosis, also you should think of it. And I was telling you about triple pre procedure. Triple pre is perioperative localization of superior edge of the placenta. We cannot do triple P when the whole placenta is adherent. When only a part of the focal placenta, the part of the placenta is adherent, then we have to localize that superior edge. We have to do devascularization with pre-op uterine artery embolization or balloon catheter in the anterior division of uterine artery and excision of that placenta. Then after you have excised that focal part, then put box sutures and then close it, and to stop the bleeding you can put Bakri balloon there, so by the pressure. So this is the triple pre procedure. So many people have done it, they have got good results with this. But this is not applicable for the whole placenta is there. We cannot remove that much of the product and then you cannot approximate the biometry. It's only in the focal part, then you can do that. So complications of conservative line, I told you, infection, DIC, sometimes some people have ended up in vesicouterine fistula, etc., etc. So what happens if unexpected, unplanned, you have taken this patient has come to you suddenly, she is for section and you have taken her into the OT and unexpectedly you see this picture in the OT. So what you will do? So just don't start doing, first call some senior obstetrician, call the team, I had told, no, urologist, senior obstetrician, inform the anesthetist, inform the blood bank, what all I had told, what you have to keep ready. Suddenly you call people for help, ask each one to phone all these people and bring the team into this thing, then start your surgery. Just because you open, don't just put in, because you'll still start bleeding like mad. You don't have time. Just to prepare, 10-15 minutes you try to prepare and then open and then start your surgery. Temporarily pause, have patience when there are such cases. And if you are in a center, it's not a center of excellence, if you are in a periphery, and if such case, if you land up, I don't mind you all just closing the abdomen and referring this patient back to the tertiary care center. Or if you feel babies, this thing is important, just open in the fundus, take out the baby, close it, and shift the patient to the center of excellence. Don't handle this case in a periphery where single-handed, no help is there. You can do more justice by not handling than handling this case. Preoperative management, I told you, especially these cases have to be managed in a daytime when everybody, don't post these cases late in the night when you don't get any help. Okay, and preoperative MRI, ureteric stenting is very important. So checklist for OT instruments also, you should have all high pressure pump, wide bore needles, all the massive transfusion, body warmers, for cystoscopy, ureteric stenting, all this vascular set, everything has to be ready in the OT. All these sets, vascular surgery, urology set, laparoscopy set, everything has to be ready in the OT. So if it is an emergency, if she lands up with you, you have to make her hemodynamically stable, order for MTP, that's massive transfusion protocol, call for help, then take an incision on the fundus, take out the baby, leave the placenta there, and you can proceed with hysterectomy. But there should be a team explaining to the attenders and taking all the consent for that. Intra-op management is preoperative cystoscopy wherever needed should be done, and ureteric stenting, though it is controversial, but I told you, as per the MRI topography, some cases it is very essential. And usually, if it is very high up, then you can do subtotal hysterectomy, but it is, placenta is very low, then most of the time you end up doing total hysterectomy. And after the delivery of the fetus, avoid giving uterotonics. Uterotonics, what happens, if it is totally adherent, it's okay, but if it is partially adherent and some part is not adherent, and if you give uterotonic, that part will separate and she'll start bleeding from there, because the whole placenta is not. So do not use uterotonics after the delivery of the fetus here. Then after the delivery of the fetus, you close that incision, then proceed with hysterectomy. Hysterectomy also, you should be very quick, and if it is very vascular, before going ahead with hysterectomy, you should do internal iliac ligation. Or if it is very bad, then you can do aortic clamping, or if it is like percreta, invading the parametrium and all, that time where you cannot go ahead with internal, you can go ahead with aortic clamping or common iliac clamping. But when you do that, you should keep the timer. Every 15 minutes again you'll have to release, and then that, because you cannot go on for hours with those, it will lead to necrosis. Then even when you are doing hysterectomy, the method of clamp, cut, drop. Clamp, cut, drop should be adopted because it will be very fast hysterectomy you can do, because we want to control the bleeding as early as possible. So clamp, cut, drop, and then doubly ligate later. You can do that. Then the procedure will be faster. And at the end, you have to keep drain. And you should never attempt to remove the placenta. After delivery of the fetus, you don't even go near the placenta. Just live as it is. Just close it. I keep telling my students, Dustarinda Duraviri means this placenta exercise dusta. So keep away from that. Don't go near at all to the placenta. If you go near, you'll end up in problem. So that is this thing. Just to remove. And how to reduce, the most important thing is bladder injury and ureteric injury, and how to reduce these urological injuries. First of all, one thing is inform the urologist, have the urologist watched for the case if you are suspected bladder invasion or ureteric, or at least you ask the urologist to be in the OT before you start the procedure. Preoperative ureteric stenting is a must if in those cases, not all, where there is bladder invasion and parametrial. And when they are doing stenting, let them do the cystoscopy, because that will tell us how much of the bladder is involved. They can see the vasculature from inside, and this help to assess the placental invasion in the bladder. And direct tracing of the ureter intraoperatively, we can trace and find out. And deliberate cystotomy, if the bladder is involved, don't try to dissect it that time. It will lead to more bleeding. You can do deliberate cystostomy, remove the plast which is involved, then you are doing more justice. Otherwise, if you are just separating, it will go on bleeding, you cannot see, and you will end up in problem. And filling the bladder during surgery will help you to define the upper borders, aids in better dissection. And we have to take steps to avoid major hemorrhage. When it is bleeding, you cannot see where is bladder, where is ureter. In that, you try to do dissection, finished. You end up in all the problems. So try to avoid heavy bleeding. It will limit your visibility. And sharp dissection of the bladder is advised. And don't dissect bladder from the lateral side, because the bladder pillars are highly vascular in these cases. So not from lateral. Center only sharp dissection is advised, because lateral, if you put heavy, highly vascular bladder pillars will get injured and heavy bleeding will start occurring. Or some suggest, some people do suggest that before you deliver the baby only, you separate the bladder with sharp dissection and push it, because that will give a better definition than when a contracted uterus. So that is again one more way of preventing bladder injuries. So these are the cases which after hysterectomy. Then what about postpartum management? They have to be in the ICU, blood transfusion has to continue, all coagulopathy and anemia should be corrected, close monitoring for input, output, drain output, etc., vaginal bleeding, and definitely post-operative prophylactic heparin has to be given, and pneumatic limb compressions. Because we are handling with the vessels, we should give them prophylactic heparin after the bleeding has stopped, or at least give pneumatic limb compressions. So the gray zones, very question mark zones in this management of placenta acretitis, whether routine role of pelvic devascularization, whether has to be done in all cases or not, with uterine artery embolization, etc., placement of these balloon catheters, and conservative management is a big question mark, whether to give for the patient or not, because we are not very sure when it is going to go for apoptosis and completely shed off. So stepwise approach, which I have talked, just a summary: establish the diagnosis in antenatal period, explain the seriousness, arrange for arrange for teamwork, and you should be well versed with the intra-iliac ligation. You should have a senior gynecologist. Vertical incision only vertical incision, where you are able to see up the side walls of the pelvis should be clearly seen. So vertical incision, again classical incision on the uterus, take out the baby, stay away from the placenta, don't touch the placenta, and fast hysterectomy with clamp, cut and drop, and sharp dissection of the bladder. Everything should be very, very fast, and in needed cases aortic clamp or common iliac clamp, and doubly ligate all the pedicles, and at the end of this thing palpate for the femoral pulse, because if this heavy bleeding you should not have clamped the extra iliac, etc., and close the abdomen with the wide bore. This thing. The deadly disease of accrete are delayed referral, delayed cesarean, unscheduled, and delayed decision for hysterectomy. Hysterectomy decision also has to be taken very fast, delayed. Deficiency or time availability because of extensive adhesions, no time. Deficiency of blood and blood products, deficiency of ICU beds, especially in an institution like ours, and deficiency of multidisciplinary team, all these deadly disease can end up the patient in more complications and mortality. So neonate is also important. Neonate baby also needs NICU because most of these are preterm, and suddenly sometimes because of heavy bleeding, hypoxia, and again problem to the baby. So all this complex, so you should have a senior pediatrician also into picture to save the baby. So in conclusion, early diagnosis, multidisciplinary planning and management, good coordination and communication between doctor, patient and patient relatives, good NICU fertility is important and essential requirement to bring good outcome in both mother and baby in case of placenta accreta. Thank you.
Any questions? Ma'am, I have one question. How long can you clamp the aorta and with what instrument do you clamp?
Actually, Dr. Paley's aortic clamp is there. It's like plain here and only at the end when this thing close. It's very safe. His videos are also there, it's available. But if you don't have that, then what we ask is, we ask one strong PG to put a pressure on the aorta. Like, if you don't have that, at least we can do that.
How long can you?
You can put for 15 minutes, little release, again put for 15 minutes, no problem. Yeah.
Thank you, ma'am. You addressed the topic very well about the risk factors, diagnosis, management, and everything about adherent placenta. There are so many PGs in the hall. I think this topic has scared them.
No, I hope I have not scared you.
I wish none of the obstetricians have such a case out of the blue
Actually,
on the table.
To reduce this, then we have to reduce our C-section. And in C-section also, the technique is more important to reduce the C. Even if you have done C-section, the closure, how you do. Full length, non-locking closure is better than locking. So when you lock, we are creating hypoxia and then this thing. And double layer closure is better than the single layer closure. And your incision should not be too low. If it is too low near the internal os, what happens? It is more prone to develop a niche. Why niche develops is it is very too low and the cervical mucus tries to go and collect there and it becomes a niche. So that practical. So your incision should not be too low and not too high in between. It should be in the correct lower uterine segment, not near the internal os sometimes. So all these things can this thing. And because of this too low incision, so many people are ending up in a uterine niche and then all the menstrual problems and the fertility problems due to uterine niche also. So these techniques will also help and also doing cesarean not in labor is not good. It's better she's in labor when you do section. So when we do elective not in labor, it's little risky for the next for PRAS. But so many times we end up like that, but better to do it when she's in labor.
Thank you, madam. We have lots of take-home messages today.
Now we will move on to next presentation on management of central placenta previa by none other than our own dynamic, all-rounder, thorough academician, Dr. Sadhna Deshmukh, madam. She is a practicing obstetrician and gynecologist since last 33 years at Suyash Nursing Home and Ashwini Hospital. She is a trainer. She is trained in sonology and have a great passion in obstetrics. She is an excellent singer and she loves to manage events very gracefully, and we have experienced her singing also and event management in every our trip SOGS trip every year. She manages very well. Over to you, ma'am.
Thank you for the kind words, Anjali. It was really over exaggeration, I think. Good morning, respected teachers and my dear friends. I first of all thank the organizers to give me an opportunity to talk in front of this August gathering. My job is very easy after the imaging and the Kasturi ma'am's talk because most of the things and complications are covered. So I'll just take a short time. I'll just come to the point. When we classify placenta previa, gone are the old days where you used to say it type 4 placentas like marginal and partial. Now current classification, placenta previa which covers the cervical os, low-lying placenta where the placental edge is within 2 centimeters from the cervical os. This may be anterior, posterior or lateral. And the normal placental location where the edge is more than 2 centimeters from the cervical os. So please change the classification, dear friends. Now these are the 3 types. First picture you can see the normal location, second is the low-lying and third is the central placenta. The key points in diagnosis is the ultrasound technique. So friends, transabdominal ultrasound is still being done in many places as the sole method of diagnosis, which gives us high false positive and high false negative rates. So it's my urge to convey to everybody that TVS must be done. We take sufficient care to see that the probe doesn't touch the cervix. See that you keep the probe 2 to 3 centimeters away from the cervix and angulate the probe in such a way that even if in emergency, maybe the cervix is open, we will not push our probe into the cervix. The sensitivity is 88% and specificity is 99%. MRI is only restricted to see the depth of division, lateral extension and bladder involvement if you suspect PAS on ultrasound. But I'm going to restrict myself to plain placenta previa and not the adherent type. Now the timing of diagnosis. I'm sorry for this slide, this font is small. Many times we find that NT scan 11 to 14 weeks we can see placenta covering the os. But only 42% of these diagnosed placenta previas persist at term. Many of them migrate. Then during the anomaly scan, 90% of placentas migrate at the term, persist at term. When you diagnose at 19 to 23 weeks, we see the overlap over the cervix. That is, if it is 14 millimeter overlap over the internal os to the other side, it may be anterior overlapping in the posterior, lateral or posterior anywhere. So, placenta previa persisted at term only in 0%. So, all migrated. If there is a 20 to 25 millimeters overlap, it persisted in 40% of the cases. If it is more than 55 millimeters overlap, it persisted in all 100% of cases. So, at the anomaly scan, it will give us an idea whether these are going to migrate or these are going to persist. Therefore, friends, repeat USG at 32 weeks is mandatory for the confirmation of diagnosis. Also, we must repeat USG 7 to 14 days prior to LSCS. We know that the lower segment is just 5 millimeters at 20 weeks and more than 50 millimeters at term, hence the migration occurs. So, do not report placenta previa at NT scan. You can say just it's low-lying, anterior or posterior, but because the patients may get afraid and they may take a lot of stress and panic situation arises. Again, when we do the diagnosis, location, anterior, posterior, lateral, we have to look for the subcensurate lobe. We have to accurately measure from placental edge to the os. Look for cord insertion to rule out vasa previa. Character of the edge thickness. This is one of the important things all gynecologists must look at it. Though the radiologist may do the scan and send the patient to you, we must ask them how thick is the placental edge, because more than 1 centimeter placental thickness leads to many APH and increase in cesarean rate. It was 88% in a thick edge versus 40% in a thin edge. Same is the LSCS rate also. Then the presence of marginal sinus, which is seen as a discontinuous venous lake or a hypoechoic area with a venous flow. If that is there, we must think she put into a high risk category and she is likely to bleed. Avascular edge or a thin edge, the risk of APH is low. Also, we must look at cervical length.
Cervical length, encirclage only is done if the cervix is short, less than 24 weeks of age, and suppose a patient comes with history of bleeding, but there is no active bleeding at that time with a short cervix, because open cervix may again precipitate bleeding. Bladder should neither be overdistended nor empty, because the overdistended bladder, both the anterior and posterior edges may look approximated and falsely diagnosed. Also the empty bladder. Focal uterine contraction may be mistaken for placenta. So we must wait to see, if you see another echogenic structure like placenta and in the lower segment, we must wait for it to go away. One more important thing, the sagittal, parasagittal and transverse views are mandatory. Now, as madam has well said, on transabdominal movement, ultrasound, we should do a fan-shaped movement from left to right in the sagittal plane, and the transverse movements from top to bottom. So this is a sweep left to right and above downwards. Similarly, while doing transvaginal, we have to take a sagittal view where you can see the cervical os, go to either sides of the uterine wall, and also look for the transverse, so you can see exactly from all the 360 degrees where is the exactly placenta and how much it is covering the os. The color Doppler is must to look for vasa previa, marginal sinus or pars spectrum. Now these are the, do you have a pointer? These are a few images. On top two images you can see the placenta covering the os, and the upper two images show a thick placental edge on the os. While as the lower two images, no, it's not, yeah. Now you can see this is a thick edge covering the os, here is also a thick edge, whereas this is a thin edge covering the os, this is a thin edge covering the os. So we have to look at these things. Here is the central placenta previa, Here is the obvious central placenta previa. Now, this is a scan I did yesterday on a 14-weeker patient. Here, I have taken 3 planes. Now, this is the sagittal plane where we can see the overlap is 22 millimeters from the internal os. Now, these are the 2 parasagittal planes to the right and to the left. We can see the placenta covering the os, and this is a transverse plane where in the lower segment just above the cervical canal you can see the placenta covering the whole of the central portion. Now this is a case where there is a marginal sinus. Here we can see this hypoechoic area and the color flow with the venous flow in it. Now the cervical length, if it is less than 3 centimeters, chances of APH are there, because if cervix is short, dilatation is there, separation occurs, again it induces contractions and the vicious cycle goes on. Although planeless, 1/3 of the patients of placenta previa are associated with short cervix and contractions. Therefore, cerclage only if CL is less before 24 weeks, otherwise you have to manage according to the bleeding. Now, what are the high-risk cases? The high-risk cases are those where the first episode is less than 29 weeks. We know the 1/3 rule. 1/3 rule is that 1/3 of the placenta previa patients bleed at less than 30 weeks, 1/3 may bleed from 30 to 35 weeks, and 1/3 may go to term. It is said that 10% of the cases of central placenta previa do not bleed until we take her for cesarean section. Now the thick edge, short cervical length, previous LSCS, a remote location from the setup, lack of transport facilities, and social and financial factors, I feel these are the risk factors for placenta previa, and we must work on it. Coming to the antenatal care, tailor the antenatal care according to each case. You just cannot have a blanket treatment or admit all the patients or send the patients home. It all depends when she comes with the first bleeding episode, whether she has recurrent episodes and many factors so on, and what is her distance from the hospital, etc. We have to assess the risk factors. Hospitalization till delivery are reserved for the cases who have recurrent bleeding, maybe recurrent bouts where the cervix is dilated and you have to talk to the patients. Correction of anemia, Here I would not like to, tell other management like iron and this, I'm just pertaining to the placenta previa. Delivery must be done where resources are available. Now, in a country like India, we say it is a tertiary center, but I think most of the people sitting here, doctors sitting here must be having quite a nice setup where a nice OT is available, there are helping hands or many surgeons coming up. So every time in India it is not possible that we deliver at a tertiary care center. Only where good resources available you can go. Of course it is a teamwork. Check the access to the unit, the transportation, the blood transfusion services. We have to have a dialogue with the relatives regarding the mode of plan. We have to document. Mind it, every time in the antenatal care, we do not take in writing, but in these cases, we have to take in writing from the patients that they have understood what is the diagnosis, what are the risk factors, and what all can happen regarding the mother and the fetal morbidity and mortality. Documentation is must, and we have to document whether patient has agreed to our counseling or they have denied. Suppose we have asked her hospitalization. We have asked her to come at these weeks. We have to make a chart and take a consent if they are not willing to follow up according to our advice. And of course, plan the visits and the USG timings, and the warning symptoms must be told. Everyone knows that. I think I don't want to. Now, strict bed rest. If a patient is diagnosed placenta previa, she doesn't have bouts of bleeding, her cervix is not open, you just cannot say strict bed, dhopun raha, bedpan rest gya. So strict bed rest may lead to very lot of stress and depression. So in selected cases, you can allow just routine light activity. There should be no sexual activity, no pelvic examinations, and TVS is done only by the experienced sonographer. Now the timing of steroids. Steroids are given when the delivery is expected within 7 days. High risk cases, less than 34 weeks, otherwise at 35 weeks. Regarding tocolysis, there is no role of tocolysis except a judicious use in selected cases where contractions are there and you have to prolong the delivery for 48 hours with controlled bleeding and hemodynamically stable patient. Anti-D must be given with first episode of bleeding. Decision of delivery, we all must follow the protocols. 36 weeks with risk factors, considering the age, the parity, the thick edge, previous vaginal delivery, etc. 37 weeks, if there's no risk factor, patient is stable, she hadn't had many bouts, and the hemoglobin is good. Ultrasound must be done 7 to 14 days prior to LSCS to know the presentation, the cervical status, and of course, as we know, if there's small overlap, we want to see the migration. And of course, plan the place of delivery. Now, this is the conservative, we all know McAfee and Johnson's regime for conservative management. If she is bleeding, then depending on the gestational age, if she is less than 37 weeks, you give steroids, and if she is hemodynamically stable, plan her Caesar at 37 weeks. If she is bleeding, give her steroids, or you may deliver any time. And more than 34 weeks, you have to admit her till delivery and transport or arrange adequate blood. If she is in a low resource setup, you have to transfer the patient. If less than 37 weeks and bleeding, or more than 37 weeks, directly go for cesarean section. If she is not bleeding and she is less than 37 weeks, repeat USG at 36 weeks, warn her about the bleeding, and if more than 37 weeks, plan the delivery. This is examination OT double setup. Here I remember Sardesai madam's words when we were PG students. The patient used to be taken, no, these are in selective cases, if you feel there is a thin edge, there is not exactly central placenta previa. Those days we didn't have any ultrasound machine in the department, so many times we would go for it. This is becoming obsolete now, but in selected cases where the patient is not bleeding, she is term and you have decided to deliver her, it is done only when the delivery is undertaken. It is contraindicated in severe APH. We have to keep the team scrubbed and ready. The anesthetist, pediatrician, all should be in the OT with all the trolley, everything ready, and blood transfusion, and products ready. Catheterize the patient. First, the fornices are palpated, and if bogginess is felt in the fornices, the procedure is abandoned. If the fornices are free, you may feel the presenting part of the head from that. Then you may gently go through the cervix. If it is open, if it is closed, please do not force your finger. Then you may feel the membranes and do a controlled ARM. if there is fresh bleeding, immediately LSCS should be done. So this has a role in some cases, I feel. Now, on the day of LSCS, all central placenta previa, we have to plan LSCS. One important thing that, as madam has said, we have to pose them the first thing early in the morning. We have to have a good team of 2 to 3 gynecologists, a helping hand from the team, all blood products ready, and we should have adequate time. That day, it's better we don't plan any OPD because you are under stress. You have to do the cesarean section. We do not know how long it may take. So it is better that you forego rest of the planned things and keep adequate time for this. Keep adequate blood components ready. Post when the whole team is ready. Everything has been discussed, 2 surgeons, expert anesthetist, pediatrician, and every staff member is ready for the drill. Wide bore cannula or a central line catheters must be kept ready. Extra pair of hemostat forceps, it's always mandatory because in the routine LSCS plan, I think we keep a 3 or 4 pairs of hemostatic clamps. So 8 pairs of hemostatic forceps must be kept. In my experience, I always start 1 gram of tranexamic acid drip in all the patient in the first pint of RL. I mean, just don't give it on the table because it will take some 20 to 30 minutes for the action for the injection, and it's my dictum that I follow, and you will not believe the placental blood is really very nice and less vascular. We have to keep all balloon, clamps and adequate mops ready. Important thing is consent. Consent for the blood transfusion, the operative procedures. You may explain what are the conservative procedures, what is the SOS hysterectomy consent. Preferably, it is better to go for video consent because if for your bad luck, if untoward things happen, fetal morbidity, mortality or maternal you have to have a video consent. 2 relatives with the patient herself should sign the consent. And it should be tailor-made consent. It should not be a consent which is printed for all surgeries we have. Now, when we take the patient for cesarean section, we must consider that when there is low-lying placenta, there's a lot of vascularity and there's a lot of anastomosis, not only from the internal iliac artery, it is the external iliac artery, the inferior mesenteric artery, sacral arteries. So just going for uterine artery ligation may not be sufficient. So we have to understand what things may go wrong. On the day of LSCS, regional anesthesia is preferred because it does not interfere with uterine contractility. Only GA is reserved for the patients who are bleeding and other obstetric causes. If there are engorged vessels on the surface, avoid opening the psychouterine pouch and the bladder dissection. Take a J-shaped incision. Now, depending on the location of the placenta, if you can go little higher than the previous, maybe many of these are previous LSCS cases, or you can see the engorged vessel, you go a little higher than the routine lower segment incision, take a J-shaped incision, and knife is pointed upwards so that we go from the shortest route to the membranes. So this is one important thing I sought. Second thing, if an assistant presses down the placenta, maybe the membranes will bulge and it would be easier to rupture the membranes. But sometimes it may be very difficult, otherwise you will have to go very high up, we may need to cut through the placenta and quickly deliver, as we know it will be fetal loss. Timely uterotonics should be given and everything must be pre-filled. You have to check with the anesthetist that all the syringes are pre-filled. This is the lower segment vascularity as we see in many of the cases. Now, after doing everything, we have done all the job and still patient has PPH. There is a lot of bleeding from the lower segment. Now, what are the things we can sort to? First thing, we have to apply multiple clamps, the green Armitage and Ellis clamps to at least control the edge bleeding because the edges are also vascular at every spot. We have to exteriorize the uterus. We have to place Z sutures in the placental bed. That we have been doing since long. Even at the angle, we may have to place the Z sutures. Sometimes we may have compression at the bleeding sites with mops there. Last time I remember, there was a case of PPH and we compressed the uterus bimanually 5 minutes, exactly from the clock. So just compression can cause, reduction in the bleeding. Then we may sort to bilateral uterine artery ligation. Other methods are Dr. Panikar's funnel stitch, Bakri balloon inflation, Bilateral internal iliac ligation, if there's an expert surgeon. Of course, we have to have a surgeon who can do bilateral uterine artery ligation. Then, bilateral internal iliac balloon catheter by the intervention radiologist. Aortic clamp, which is devised by Dr. Piley, and the last is obstetric hysterectomy. I would just like to highlight a few. Rest of the things Madam has already covered. The choice of method to control PPH, it depends on the setup, the expertise of the surgeon, the available gadgets, then the patient's parity, severity of PPH, duration from the onset of PPH, and available team members. Decision is also made with the anesthetist to judge the condition of the patient and how further she can tolerate the blood loss and availability of the blood products. Now friends, this is Panikar's funnel suture. Now you can see, this is the LSC, this is the LSC scar. So bladder is gently pushed down and 1 centimeter above the cervix, anterior to posterior, 1 number vicryl is passed. It is, you just go above to cover the whole lower segment. Again it is taken anteriorly and above 1 centimeter above the LSC scar, take it inside. Below the scar you take it outside and tie it so the lower segment is compressed, the anterior and posterior walls come together, and this has to be done on both sides. This is the lateral view. Now this picture will show you that on right as well as left the sutures are taken so that quite amount of bleeding. There has been papers here with Dr. Panikar and a paper at China also that they have said that the 80% cases the blood loss is reduced and we can avoid hysterectomies. Yeah, this is the same thing. Now, I think everyone must have a Bakri balloon in the theatre, and we all of us have now, I think so. Now, in some cases where the bleeding is not very alarming, but there is constant oozing, balloon can be inserted through the incision, inflated with 150 to 200 ml saline. The vagina is packed, and the ends are sutured, Z sutures and interrupted sutures over the balloon, so that just see that the balloon wall, is not included in the suture, and vaginal packing is done to prevent the dislodgement, and the drain is kept. And one more thing, before closing the abdomen, one other person can check how much is the bleeding from the drain, and then we can close the abdomen. This stands true for all the conservative approaches, I think, because after you close the abdomen, if she bleeds, we can't afford again laparotomy. Now the next is Dr. V.V. Piley's aortic clamp. I think since I've prepared for this talk, I think 2 to 3 persons in Solapur must have this clamp. Does anyone have here? No, okay. Now this is a 22 centimeters long clamp with a smooth catch. It has a gap of 2 millimeters in it. So here what is done, when the patient is bleeding, we may take the decision of either conservative method or radical obstetric hysterectomy is to be done. This clamp application is very easy. You just exteriorize, push the uterus in front or exteriorize the uterus and go on the spine to see the bifurcation of the common iliac and the aorta. And the aorta is held with a big Babcock forceps, and at the lowermost point of aorta, this clamp is applied. Now, this clamp has a gap in between 2 millimeters so that the aorta is not crushed. And it is said that this clamp can be kept for 60 minutes. The thing that initially they used to ligate the common iliac, but the chance of ureteric injury are very common in common iliac clamps. So this is, I think, everyone must have this clamp whenever we manage such cases, and it is really a wonderful method. And the advantage is that it can be clamped by any gynecologist. Only thing we have to dare to do that a couple of times. Maybe we can do it in front of a senior surgeon like Kumthekar sir or Dabde sir or Pawar sir. I don't know who are all. They are the lifelines of Solapur. With this clamp, the collateral circulation in the pelvis is reduced, thus reducing the pulse pressure. It can be used for any obstetric hemorrhage requiring obstetric hysterectomy also. Now, one good news for Solapur is we have an intervention radiologist called Dr. Faisal here recently. And I had a word with him and he has shared his experience. Also, he has given me the slides for this internal iliac balloon occlusion, and I'm really thankful to him. Now, this is the pictorial diagram where the balloon is inserted in the internal iliac artery. Now, the left. Here, in all high-risk cases where the patients are likely to bleed in a resource setting, if patients can afford, contrast is injected through the femoral artery. A 4 to 6 millimeter catheter with a tip balloon is passed through the femoral artery, and this is taken. This is all done in cath lab under DSA. Of course, we can't do it in OT. And then the patient is shifted to OT. When the 2000 international units heparin is given to avoid thrombosis, and the patient is shifted to OT. When the obstetrician takes the incision, or whenever he wishes, now it's time that I want the reduction in the bleeding, at the incision of the uterus or at the abdominal incision, he can ask the radiologist to inflate the balloons. Now this is the picture where the balloon is inflated with either saline or contrast medium. 2 to 5 ml of this is injected, and there we can see the inflated balloons, and the surgery is completed so that we have very less intraoperative bleeding. Now suppose after the deflation of catheter, the bleeding again starts, then in that case they can inject gel foam and do internal iliac embolization. They have some gel which they inject into it, which is permanently there. So this is, I think, a fantastic procedures in the days to come, and we can talk to the patients, and we just not decide who can afford and who cannot afford, so we can give the option to these patients. Yeah, this is the same. Now, coming to the obstetric hysterectomy, I think everyone knows if the conservative approach fails, there is no reduction after internal iliac ligation, or there is no expert surgeon to do it, and all the conservative methods like balloon or mopping or funnel suture has failed if the radiologist is not available, and the surgeon's judgment for the need of hysterectomy. It is all on the table. We have to decide depending on the patient's condition. Clamps are applied by drop method, as we all know. Lower segment is enlarged, so care taken to avoid ureteric injury. Bladder is separated from the lower part of the, if it is densely adherent, you may go laterally. That is Pelosi's method. I can just show you a picture. This is a picture where sometimes central dense adhesions you can go laterally. So friends, I think that is all I wanted to talk. The take-home message for everyone is that the expert sonologist must be there for diagnosis. We have to have an appropriate ANC care, appropriate counseling, site of the delivery, planning, a teamwork, of course, a team of staff and doctors also. One important thing I would like to stress that all PG students must be trained having a PPH drill or internal iliac ligation simulation, something like that, because I think many of you go for internal iliac ligation. Now, I don't know the current scenario, maybe Dr. Pawar, is he here? Dr. Pawar must be knowing, but I think during our times it was really difficult, and all must be trained for that. So everyone must, I think, madam, we can go with this drill in some time throughout the year, where we can have a PG training for the PPH drill. Thank you. And arrange adequate blood products, and the surgical approach and decision of the methods is very, very important, and it has to be tailor-made according to the scenario. Thank you so much. Yes, sorry. Yeah, sorry. I had asked him, but I didn't get an answer. I will update on the group today itself. Yes.
I've already talked to him yesterday. What he said is the balloon itself will cost 20,000 each. So you need to decide whether you want a unilateral or bilateral initially. If there is a bilateral, the patient will have to pay 40,000 for 2 balloons itself, and another 35 to 40,000 for cath lab and his fees. So probably if we talk to him and persuade that might come down?
Only thing is that we have to tell at least 2-3 days in advance because he has to get the balloons from Mumbai. They are not readily available here. Thank you, Bakul, for giving my answer. Unfortunately, I don't have a picture. Z suture is just, there are two types of sutures we take. One is figure of 8, where we go from one angle diagonally and take it from other diagonal. Here we have to go from one end on the same side in the same line, again go to the opposite end and go. So we have two parallel lines with a Z in between, where the thread passes as a Z. So that is shown as a Z suture.
Hello, good morning. The stitch that you mentioned about the cervical funnel stitch, I just wanted to ask you if you have any results or any experience about the postpartum menstrual flow and her future fertility?
No,
terms of
unfortunately, I don't have the data. I can post it. There's one data from China where they have mentioned, and even Dr. Panikar, they have mentioned that there is no complication for that.
Yeah, I mean,
Because it's an absorbable suture. There we just want to approximate to this and also constrict the lower segment. So the vertical length will, compress it, and the anterior-posterior, the segments are approximated, the lower segment
it's
on
sort
both
of
sides.
similar to the
Yeah.
B-Lynch suture except for the fact
B-Lynch
that it's
mainly we use for atonic
cervix.
PPH, where a higher segment, this uterus is flabby. I have not spoken about that because I have restricted to placenta previa.
Similar to that, but
Yeah.
in the
But it is easy. I think looking at the picture, everyone can try. Yes. Madam, na mic de do. So I felt this.
Sir, to your question is, there is no problem with the menstruation.
There's no problem with menstruation.
As we are running short of
That was
Thank you.
excellent deliberation, Sadhana.
Thank you, Doctor.
A comment I must give this for the benefit of the audience. Believe me, uterus is a very, very, very resilient organ. It has been mutilated, destroyed, whatever it has been done to the uterus, it stands and it recovers. So you have to believe in the uterus rather than all the procedures.
Yes. Thank you.
as we
Secondly,
all,
I must add here also for the particular juniors, as it has been told by Dr. Sadhana already, you must learn internal ligation, the gynecologist. There is no time to call external help. It has to be a very quick procedure. And so you, at any cost, you must learn, call the seniors if possible, to demonstrate how internal ligated it is not needed. You can just approach and try to learn internal iliac ligation at any cost. Thank you.
Thank you so much.
Thank you, Kumtekar sir, for your suggestion. We will request our President Madam to have a workshop on internal iliac ligation. And you rightly said uterus is a very resilient organ like women. And thank you, Sadhana Madam, for your wonderful exhaustive talk with nice practical take-home messages and detailed ultrasound tips and tricks. Thank you very much.
I request our President, Dr. Khate Madam, to felicitate Dr. Sadhana Madam.
We move on to the next most needed talk on prevention and care of atonic PPH by none other than Dr. P.P. Patil, multifaceted, dynamic personality. He is our own VM Medical College student and topper of his batch. He has done DMAS and FMAS from New Delhi. Other than academic excellence, he is a passionate high-altitude trekker, completed Mount Kailash Parikrama and successfully accomplished Onam Peak Summit in September. He is a trained yoga performer for more than 2 decades. He's a founder president of an established school and at Kauthe Manga. Over to you, sir.
Thank you very much. Respected chairpersons, distinguished dignitaries, and the entire OBGY fraternity present over here. Lot of thanks to Solapur OBGY Society for inviting me to deliver my talk on prevention and cure of atonic PPH. It reminds me today of those days at VM Medical College Solapur, where Dr. Sardesai madam talked to me, and today I feel as a proud student of her. She used to stand for more than 2.5 hours to teach vaginal hysterectomy to us as an assistant. So that was her dedication towards teaching. And mention about Dr. Dabde sir, his teaching was different. He used to ask only questions. And if you ask him questions, he used to say always, read and tell tomorrow, or take 2 or 3 days. That's our, we learn a lot from him and Sardesai madam. So, as a respect towards her, I dedicate this invention or the whatever research I have done in PPH prevention to her, and my all-time support in private practice, Dr. Somshakar Patil from Miraz, who took care of my complicated patients and complications too. So going by the statistics, incidence of PPH is 2 to 4%, some say it is 6%. Yearly 14 million women experience PPH and 70,000 of them die. And unfortunately, every 5th happens to be an Indian woman. Certainly not a proud feeling to us as we are going to become 3rd largest economy in the world. For PPH, we give medical prophylaxis. However, patients still bleed and die. So we need to readdress this issue. Question is, why so many deaths occur? There are problems at the setup level, there are problems with professionals, and there are problems with the methods which we use. Our population is mostly in rural area, setups are also there, small setups, transportation is very difficult. Sometimes blood bank facilities are not available everywhere. There is lack of teamwork support because of small setups and single-handed working culture. And professionals, each and everyone is not able to apply or execute the various procedures which are available for PPH prevention and cure. And the methods, there are problems with methods too. The many primary methods are not effective every time, like balloon and cannula. And the effective ones are too complex to be performed by everyone at every setup. And on the top of that, handling PPH after cesarean section is more difficult than handling PPH after normal delivery, because always there is delayed feedback from the patient of cesarean PPH in cesarean section. Patient is under anesthesia or sedation and she will notice the bleeding, only the blood reaches to the shoulders. And there are concerns while using primary methods like balloon, cannula and packing because of fear of disruption of sutures. Let us see the after effects of PPH death. To the patient, there is serious mental trauma, there is loss of menstruation and fertility, there is loss of life. And to the professional, it is a nightmare situation, especially for a peripheral professional. And when the patient is needed to transfer, the relatives become angry, and if patient dies, they will cause physical injury, damage to the hospital property, and then antisocial elements get involved. They will extort a lot of money from you. There is professional loss. And combined effect of that, it gives a serious mental stress. You know, one of our professionals from Rajasthan committed suicide because she was unable to handle this stress. I will say the after effects of PPH death are devastating. So prevention is better for this. Let us see the various methods which are available and the after effects. When PPH occurs, we give repeat medication and many times bleeding is controlled. Uterine packing and balloon, they work but may not work in severe atonic uterus because there should have some tone in the uterus as a counter pressure. So if in severe atonic uterus, the uterus expands beyond the capacity of balloon. In cannula, it is not fitting to the uterine cavity and it gives discomfort to the patient because it has to be kept for a prolonged time. There are problems with arterial ligation. It takes time. It is effective, but expertise is needed. May not work in severe atonicity as the uterus may pull blood from the ovarian arterial anastomosis. And if bilateral internal iliac arteries are ligated, sometimes there is a risk of bladder necrosis, thigh and buttock claudications, and thrombosis of external iliac arteries. OH is a definitive method, but further fertility is lost and expertise is needed. And tertiary care center is needed. Compression sutures work better, but they have some issues. So due respect to Dr. B. Lynch and various pioneers in compression suture, let us quickly go through the various modalities available. This is a B. Lynch stitch where uterine cavity is needed to be reopened. And then again, special long straight needle and ligature is required and the edges will bleed till they are resutured. This is Hemorrhage suture, 2 vertical suture, but it goes through and through the anterior and posterior uterine wall in lower segment. This is Cho suture. It gives segmental contraction or compression of the anterior and posterior uterine walls. And there is compromise of the natural drainage of the uterine cavity. This is Pereira, not very popular. This is MY suture or My suture. Again, it compresses the central part of the uterus. This is Makino Takeda, just like Heman, but there are 2 sutures on the lower segment too. This is Kuwaba suture. Again, it gives segmental compression, and there are 2 horizontal compression sutures which obstruct the natural drainage of the uterine cavity. So the collective challenges are opening of the uterine cavity is required. They require special ligature and a needle. The straight long needle can injure bowel posteriorly. The loop formation, if this loop slips, there will be bowel obstruction. Myocardial ischemia and necrosis, there are chances of this because the uterus is compressed, anterior and posterior wall of the uterus is compressed at the same plane. Then potential threat of pyometra because of obstruction to the uterine cavity. And uterine synechia formation because of too tight closure of the anterior and posterior uterine walls at same plane. Let me take you through my methodology of addressing this issue. You will all agree that nowadays equal number of patients are delivered by vaginal or abdominal route, more in private setups and less in government hospitals. But combined they are 50-50. So my understanding is that if compression stitch is applied in cases prone to atonic PPH during cesarean section only as a surgical prophylaxis, nearly 50% of incidence of PPH can be brought down drastically. And the remaining cases can be handled when PPH occurs after normal delivery or cesarean section by applying the same procedure. I have come up with a technically very easy and highly effective compression suture which can be used as surgical prophylaxis and as a therapeutic procedure also. It gives benefits of compression suture and arterial ligation together, avoiding majority of their issues. Moreover, this procedure is also highly effective in PPH and other obstetric hemorrhages due to atonic uterus. So where this stitch can be applied? This stitch can be applied as a surgical prophylaxis or as a preventive measure as like medical prophylaxis and as a therapeutic procedure. As a preventive measure during cesarean section for prevention of PPH when uterus is found atonic after closure of the lower uterine segment. When there are predisposing factors for PPH in that patient, like over-distended uterus in twins, triplets, polyhydramnios, prolonged labor, elderly gravida, multigravida, IVF pregnancies, in IVF pregnancies, all known progesterones and uterine relaxants are used, and there is a tendency of PPH in such cases. And they are elderly too. In eclampsia, in cases of ruptured uterus, retained placenta, and if there are associated medical disorders like anemia, which is most common. In anemic patients, if stitch is applied post-operative, number of units of transfusion is decreased. Thrombocytopenia due to various reasons, factor deficiency in bleeding disorders, RH negative cases, especially O negative, when blood is not available, we can think of it. Heart disease cases, in heart disease, there are restrictions to use medical prophylaxis because it is going to alter the cardiac status. Again, if bleeding occurs in a case of heart disease, the afterload is decreased and patient goes in shock early, and we have to give fluid for that, then it increases the preload. In either condition, it alters the cardiac status. So we can think of applying this stitch there. And as a prophylaxis, during second trimester hysterotomy, when uterus is found atonic, and as a therapeutic procedure, whenever there is established PPH after normal delivery and cesarean section, and excessive PV bleeding after second trimester MTPs and IUD terminations. These are various indications where I use this stitch: uterus very atonic, less atonic, small uterus, or uterus relaxing in between contributes more, over-distended uterus due to twin pregnancy, over-distended uterus due to large baby, prolonged or obstetric labor, elderly gravida, multigravida, IVF pregnancies, RH negative, anemia, and thalassemia trait is also included in it because they are usually anemic. History of PPH and blood transfusion in previous labor, retained placenta with MRP during cesarean section, especially when there is corneal implantation of placenta gets retained. And PPH after vaginal delivery in second trimester, rupture of uterus. Total 63 cases were applied this stitch, and the results were highly encouraging. Out of 297 consecutive LSCS cases, 61 were applied prophylactic stitch. None of the patients had PPH who were applied and who were not applied the stitch. So there was no PPH in patients who were not applied the stitch, which indicates the selection was appropriate. And bleeding was successfully controlled in other cases, that PPH after normal delivery and rupture uterus, and no complications were observed. So I will take you through the diagrammatic representation of my stitch. So the ligature is tied on the anterolateral aspect of lower segment on right or left side, and it is passed posteriorly through the same side, through broad ligament posteriorly on right or left side. Then it is brought up in oblique direction to the fundus on opposite side and brought vertically down and sutured to the anterolateral aspect on the lower uterine segment on other side or contralateral side. The same procedure is repeated again. It is fixed to the lower uterine segment on one side, brought posteriorly, and then brought vertically down and fixed to the anterolateral aspect on the lower segment. So here, by passing the ligature posteriorly through the broad ligament, it gives a temporary or transient compression of the uterine, ascending uterine arteries on both sides. And there is compression in the oblique direction, in the direction of oblique uterine muscle fibers. There is compression vertically down in the direction of vertical muscle fibers. And because we are passing it posteriorly through the round ligament, there is lateral to medial compression when they are tied both together. So it gives compression in the direction of circular muscle fiber. So uterus is compressed uniformly here, as well as ascending uterine arteries are compressed too. And there is no need to fix it posteriorly because we are almost at the same level as at the anterior level. We are not going through the uterine cavity. Therefore, there is no threat of pyometra or there is no obstruction to the natural flow of the uterus. Again, the anterior and posterior compression is not at the same plane. So it is no too tight closure or no too tight compression. So the synechia formation will not be there. The ligature will not slip easily because it is crossed obliquely and they are crossing each other posteriorly. So it will not slip and loop formation will not be there. So these are the advantages of it. I will demonstrate it on myself. Consider this as a uterus. Forget my head. Because there is nothing as my wife said. This is round ligament. This is round ligament. There is broad ligament here. Then these are uterosacrals. And uterus is standing on uterosacrals.
Hello.
So I am fixing the ligature on lower segment, and during cesarean section on the and in case of cesarean section on the scar, because scar gives better strength. So two bites are taken for better grip. Now this is broad ligament. This is broad ligament, this is round ligament. And it is passed posteriorly, like this, through the broad ligament, in oblique direction. And at the fundus, it will come vertically down and tied on the contralateral side. So, when I will pull it, it will get compressed. So the same procedure is now repeated on the other side. So coming back to the original side, and it is tied there. So it gives uniform compression of the. This is flabby uterus. It is too flabby. So now it will not bleed.
Any doubts on this application of the stitch? Dr. Patil will be very happy to answer.
That the first stitch we are taking, that is from the uterine tissue, or it is from only broad ligament?
No, broad not. It has to be anchored on lower segment.
Lower segment, it is from the uterine
if it is
tissue.
very thin, then you have to anchor it at the junction of upper and lower segment.
Okay.
When it is very thin, it will cut through, or that will roll over the upper segment.
Okay.
We have to fix it to the uterus.
The first is just to obliterate the uterine artery.
Uterine artery. Okay.
Yes, we are in conference. So I am removing my stitch.
Sir, I have a doubt. On
Lot
the
of
suture
thanks to
packing.
Dr. Aivale or Dr. Jadhav and Aivale for making this ligature available.
Sir, at this moment, can you explain, the LSCS wound is open, right, when you are putting this suture?
No, no.
It is closed.
It is after closure.
It is after closure.
It is supposed that sometimes, many times uterus contracts when the lower segment is closed. So we have to wait for some time. And if we, yes. So let me take you through some videographic demonstrations. This is normal, well contracted, well retracted uterus. It is a firm globular structure. And there are no indentations over it when the finger is pressed over it. So this type of uterus will not bleed. That is my routine observation, and also you will find it. So even if patient is O negative and such type of uterus is there, I do not put this stitch. This is the exclusion criteria. This is mild atonic uterus. See, there are indentations over it. It is having potential for PPH. And it is also flat. Anteroposteriorly, it is flat. So I will definitely put a stitch in such cases. And this is severely atonic uterus. And here comes the real nightmare situation if proper method is not applied. So this patient was given carbetocin when it was introduced for the first time, and still it was not contracting. I couldn't give other medications because there were no reports available whether it has to be combined with methergine or oxytocin. No question of oxytocin when carbetocin is used. So I waited for some few minutes to get the placenta separated, but it couldn't separate. After 3 to 5 minutes, it contracted a little, and I removed it manually, but it started profuse bleeding. Myself and my assistant had to squeeze the uterus in our hands, lateral to medial and above downwards, till the lower uterine segment was sutured. And immediately I took the decision to put the compression suture. So this video will explain the application of this stitch. I took it in continuity with the suture which was there, which was not cut after closing the lower uterine segment. So uterus was pulled to the opposite side, cornual structures were pulled up and laterally to expose the avascular area in the broad ligament. Needle was touched anteriorly, uterus was pushed forward, and then ligature was brought in oblique direction towards the fundus on opposite side, little lateral to the midline. And it was fixed to the anterolateral aspect on contralateral side. The same procedure was repeated on other side. You should put index finger posteriorly. Then the broad ligament will be exposed properly. Under vision needle has to be removed because there are boil, chances of boil injury are there. Then coming to the original site, I fixed the ligature, and there was no post-operative bleeding, and no transfusion was required for this patient. So with this method, it was helpful in severe atonic uterus. This is a demonstration in a case of normal delivery. This patient was second gravida, delivered. She had a history of PPH and blood transfusion in first delivery. She was there with me up to 7 months and ran to my colleague. And after, when she landed up in PPH, he called me that sir, your patient is bleeding. So I took my cesarean section drum, one assistant with me, went there, called the anesthetist, patient was taken to operation theater, and blood was sent for grouping and cross-matching. Another assistant was called by that first anesthetist for her help. She had a blood pressure below 80 when we opened her. Bladder was separated. Meantime, she was given 2 methergine, 2 carboprost 125, 20 units of oxytocin in first drip, and 20 units started in second rib. Look, the uterus is looking pale. Now, after separating the bladder from lower segment, 2 bites are taken to fix the ligature. It is vicryl number 1 on thin round body needle. If we take thinner vicryl than this number, there are chances of cutting through the uterine tissue. Now the ligature is fixed on left side. Uterus is pulled on right side and the corneal structures are pulled up. So it beautifully visualizes the broad ligament. And there is a finger, index finger posteriorly. So touch the needle on anterior lip of broad ligament, push the uterus forward. And under vision, we have to pierce the needle. So it will not damage the posterior structures. Though the uterus looks well retracted, she had a continuous trickle of bleeding. Now it is brought to the fundus on opposite side, little lateral to the midline. If you go too lateral, it will slip. So with thumb of assistant or your thumb, you have to fix it on anterior wall. So it will not change its position. Now gentle traction with needle holder has to be given because the advancement of ligature is easy, and when it stops retracting, you have to stop pulling. Otherwise it is going to get cut through. Then after taking 2 bites, ligature is fixed there. 2 bites are taken for better grip. You can either fix there, or after maintaining traction, you can go through the opposite side and fix it only once from where we started. The entire procedure takes 2 to 5 minutes. So the fear of PPH in atonic uterus will be gone immediately after applying this stitch. So we successfully controlled bleeding. 3 transfusions were given post-operatively and the patient was saved in our peripheral setup. So this is the picture after application of this stitch. Thank you. This is the anterior wall. The ligature comes vertically. This is posterior wall. You will see that all the segments are compressed uniformly, and there is no compression of anterior and posterior wall in the same plane. So the chances of synechia formation is minimized here. We are not entering the uterine cavity anywhere during application of the suture. So there is no obstruction to the natural flow of uterine cavity. So the chances of pyometra will not be there. Again, we are compressing the ascending uterine arteries at this level. And uterus starts immediately retracting after delivery. So as a process of retraction, the size decreases by few centimeters in few hours. Then the ligature will get loosened, and the pressure on the ascending uterine arteries will be released slowly. So the circulation will be restored again. So there will be no issue of ischemia of the uterus or uterine musculature. Again, a large segment here at the fundus laterally at the corneal end is not compressed too much here. There is no vertical ligature crossing over here. So this can get blood supply from the ovarian arterial anastomosis. So again, the ischemia, chances of ischemia will not be there. So this is a Doppler study after 48 hours in a case which was applied the stitch and which clearly shows the entire course of ascending uterine artery and the uterine perfusion well preserved. So we can say that there is no disturbance to the uterine circulation. This is again a below 18-year girl with small atonic uterus. The same procedure is applied. This is for a rupture uterus at 18 to 19 weeks. Rupture was through the previous cesarean section scar. But she had lost a lot of blood, so the stitch was applied and there was no post-op heavy bleeding or bleeding was not there. So it was managed with 2 transfusions. So we'll quickly go through the features of this stitch. Technically, it is very easy to apply. Minimum time is required 2 to 5 minutes. There is uniform compression of uterus. There is transient compression of ascending uterine arteries. No special ligature is required because Vicryl number 1 on thin body, round body needle is easily available. No need to open the uterine cavity. Saves time and there is no bleeding also. Bleeding is decreased. Posterior fixation is not needed, less chances of slipping. Stops bleeding immediately. Uterine cavity is not compromised. So looking at the features, you will find this as a foolproof frontline surgical methodology for PPH prevention in atonic uterus, which gives benefits of compression suture and arterial ligation together, avoiding majority of the issues. And coming to the conclusion, this stitch can be successfully used in PPH prevention and cure in atonic uterus, can be applied in cases of second trimester bleeding, in MTBs, IUD terminations, and hysterectomy, etc. Further fertility is preserved. That is biggest advantage. And many mothers can be saved. So with application of this stitch, the ligation of internal iliac arteries will be required only for deep pelvic lacerations, PPH due to traumatic reasons, but which are nowadays rare because we do not prefer instrumental deliveries, and placenta previa. And practicing this methodology, you can have PPH stress-free environment in your clinic. Thank you very much. Thank you for patiently.
Any questions or doubts? Please. Thank you, Patil sir, for wonderful presentation on prevention and cure of atonic PPH. Nice video demonstration and live demonstration of a PP Patil stitch. And thank you, Dr. Dabde, for becoming uterus for better understanding.
Atonic uterus.
Thank you once again. Thank you.
Thank you.
I request our President, Dr. Ghate Madam, to felicitate Dr. Patil sir.
Just to mention, this stitch was presented last year at AMOX Nasik, then in critical care conference at Pune, POGS conference, and where it was awarded prestigious Sanjay Gupte Award. And in December, the paper presentation was done at Karnataka State Conference, Vijaypura. Madam was there, and first prize was awarded there.
Thank you, Dr. Neeta and team for giving us opportunity to chair this session. And on this Mother's Day occasion, this appropriate topic of obstetric hemorrhage, due to which most of the maternal deaths occur, it's very apt for today. Thank you once again.
I request Dr. Ghate madam to felicitate our chairpersons. Dr. Nandamage madam. Dr. Anjali Jamma madam. Thank you, chairpersons, for chairing the session. Now for inauguration ceremony, I request all the speakers to come on dais. Dr. Patil sir, Dr. Kasturi madam, Dr. Ramlingappa sir, Dr. Girish Kumtekar sir, Dr. Sadhna Deshmukh madam, Dr. Ghate madam. Cheers. हाँ. For our panel discussion, Dr. Bakul madam is going to conduct many opinion polls. So for that we have created a separate WhatsApp group. So I request all the delegates to join the WhatsApp group for the opinion poll. All the speakers, please come on the stage. Dr. Ramlingappa sir, Dr. Patil sir, Dr. Kasturi madam, Dr. Girish Kumtekar sir, Dr. Sadhna Deshmukh madam. Please come on the stage. Dr. Karande sir. I request our President, Dr. Ghate Madam, to deliver her presidential address.
Good afternoon, everybody. Today is the Mother's Day, and fortunately, we had a CME on PPH. Postpartum hemorrhage is the common complication causing maternal morbidity and mortality. PPH is the emergency for every obstetrician has to face. It complicates 3 to 6% of deliveries, and it is the third common cause of maternal deaths in developed world. But it is the leading cause of maternal deaths in India, that is 25%. Anticipating PPH remains the challenge for every obstetrician. In this CME, we try to understand causes of PPH and how to manage PPH. मराठीत एक म्हण आहे, गरज ही शोधाची जननी. Need is a mother of research. Our today's speakers invented various stitches, various clamps, various techniques to treat PPH. For obstetrician, I would say, in words of Abraham Lincoln, I am not bound to win, but I am bound to be true. I am not bound to succeed, but I am bound to live by light that I have. अर्थात मराठीमध्ये मी सर्वतोपरी माझे ज्ञान व मेहनत पणाला लावून रुग्ण माता वाचवण्याचा प्रयत्न करेन. You all gathered for day-to-day emergency topic. You will get enriched and about the practical tips to manage PPH. Before ending my speech, I want to say Hindi song. Saathi haath badhana. All the time they are saying that it is teamwork. Saathi haath badhana. एक अकेला थक जाएगा मिलकर बोझ उठाना. साथी हाथ बढ़ाना, साथी हाथ बढ़ाना, साथी रे, साथी हाथ बढ़ाना, साथी रे. Thank you. One more thing, that is today everybody is very happy to see mother of mothers, that is Sardesai madam. And today is Mother's Day. So our team of SOGS want to felicitate Sardesai madam, our mother, on this occasion. Madam, please come. Madam, please come. Today we all feel that our mother is here.
Forward for lamp lighting ceremony.
नमस्कार माझा या ज्ञानवंदिरा
interval. Now the next half will start within 1 minute.
I would like to hand over the mic to our
Over
clinical...
to Amruta.
After the interval, I would like to hand over the mic to our clinical secretary, Dr. Lalita Agarwal.
Thank you. Let us start our second half of the session. I would like to request our chairperson, Dr. Archana Shah Madam, Dr. Meena Gunzotikar Madam, to please chair the session. Dr. Archana Shah Madam has done diploma in reproductive medicine at Yale University, Germany, has done fellowship in high-risk obstetric from Hemorrhage University, Nasik, has working as a OBGY consultant at Deep Super Specialty Hospital, Solapur, also working as a director and fertility specialist at Solapur's Infertility Clinic and Test Tube Baby Center, Solapur. She have special interested in infertility, embryology, adolescent health, and high-risk obstetric. Dr. Meena Gunzotikar Madam has done her MBBS and MD from our Vensham Medical College, Solapur, as OBGY consultant at Gunzotikar Nursing Home, also at Ayurvedic Hospital, Solapur. She has actively participated in many social activities, also have special interest in NDVH. Over to you, Chairperson.
Mike.
Thank you for the introduction. Good afternoon and happy Mother's Day to all the mothers sitting in this hall. After hearing the excellent lectures since morning, we are moving to the another session, and the talk will be on management of atonic PPH by clamp. To deliver the talk, I would request Dr. Ramlingappa sir to present his lecture. He is a professor, HOD and former director of KIMS Hubli. As a medical superintendent, he has done tremendous work to bring about many changes. He has many research publications to his credit and won many prizes and awards. He has his own innovations in the field of obstetrics. A few of them are novel techniques for treatment of PPH using transvaginal clamp, removal of missing property using calm guidance, use of vacuum or ventilles in delivering ovarian cyst during laparotomy using small incisions. Over to you, sir.
Respected chairpersons, at the outset, I would like to thank the organizing committee, Dr. Neeta Madam, and all the society members of Solapur Society for giving me this opportunity to share my personal experience of two methods. And really, the Solapur is my second mother's institute, and I studied post-graduation in VA Medical College, Solapur, and in 93 to 96, and I was in Madam unit, AP unit, and actually I was not interested in actual OBG, but when I got OBG at the first attempt in all India, I don't know what to do, but after coming here, Solapur, the environment and department and the peoples and patient, actually I continued. And after a few months, actually I got MD medicine in KIMS Hubli only, but I could not join, but I continued OBG. Anyway, it's by chance, but not by choice. But anyway, I like this OBG. And really, 2.5 years in the department, had a wonderful time in the department, and a lot of remembrance from greeting from Solapur, and especially Madam, she was my guide, PG guide, and I did Sarovar gel as a thesis because it was first time it was came in the market, and really Madam, she assisted me personally, as I already told many. She is a teacher for teachers, And first vaginal hysterectomy, always, madam, she do that, she assists everybody. So that is a really very wonderful persons like madam. And in fact, after passing, I joined Kim Subli, and I continued the work that madam used to do. So most important things that Sagdesai madam regime, the low dose myself. So previously we used to do standard pitchard regime, so a lot of toxicity, complications. Until now, more than 25 years, we are continuing the low dose Sagdesai madam regime. And of course, and I had the opportunity to assist few of the surgery like tubal recanalization and cervical sling surgery. So actually, I continued these two surgery, really gave me a lot of satisfaction, and probably I have done more than 150 microsurgery, madam, and with a success rate of more than 70 to 80% following left sterilization. And of course, cervical sling, again more than 150 both center publication already recanalization published twice. And cervical sling surgery nowadays, I don't know, postgraduate, they really have a chance to see. And believe me, and last month I did 2 laparoscopic cervical sling surgery, and it was my always aiming to do it laparoscopic, and there was a difficulty at taking a stitch from the posterior at the isthmus and negotiating behind the sigmoid colon. But anyway, we could able to do it, and thanks to all, credit goes to madam and Solapur, the department of OBG. And really, I'm fortunate to be on this August gathering to share my practical experience of my method. And here, I'm going to, as you know, PPH, I'm not going to talk much about a theoretical aspect. Already many people they covered. As Eastman in 1950 only, he told no woman should die due to PPH in modern obstetric. But unfortunately, still we see many women are dying due to PPH. And mainly it's because of too little and too late. It was highlighted in the most of the confidential inquiry into maternal deaths. And the excitement of the birth of baby, the placental delivery was looked very dull and unimportant. Many times you don't attend, and that leads to third stage complications. And PPH is the most common and severe type of obstetric hemorrhage. Still it is an enigma, and even to the present day obstetrician, if you don't intervene timely, the maternal death is going to happen. So the golden hour is very, very important. What you do in 1 hour, that's most important. And PPH, as I already told, is an enigma, and is an unfortunate side effect of a natural selection of a larger brain. And because of this, so there is a invasion of placenta. And second, as a human, PPH is peculiar to human being, and because of bipedalism, and because of narrow pelvis, and because of larger baby, always there is a remodeling of the vasculature, so that leads to more invasiveness or more placenta, creta and PA spectrum, what we see nowadays. And as you know, Indian mothers are very small, malnourished, low volume, and you should be very, very careful. You cannot, 500 or 1000 ml of definition doesn't hold good. Many times, anemic woman, even 250 ml, 300 ml blood loss is a disaster to her. And so, surgical intervention should be sooner than the later. Yeah, management of the Nita madam told me to address about head to neck as well as traumatic PPH. So these two methods, paracervical clamp and pelvic pressure packing with Polish tamponade. So paracervical clamp is my original method that can be used within golden hour at the initial management of PPH after failed medical treatment. And second one is pelvic pressure packing with Polish tamponade as a last resort. After doing hysterectomy, many times So still bleeding continues, and when you shift the patient to ICU or ward, and if you don't keep the drain, then many times patient have an internal bleeding and DIC, patient will die. So that is a story and scenario what we come across. So this is going to be helpful. So as I already told, so these were the main causes already has been discussed. Many times diagnosis is delayed. So because of so many factors, one is assessment of blood loss may not be accurate and slow trickle and for long time. So this will sometimes mislead, and because of hemodynamic changes, whatever the changes in the vital parameters, so they will appear late. By the time patient will be bad, and then when we act, it will be difficult. So especially concerns in the developing countries, one is inability to diagnose PPH, and second, limited availability of resources like pharmacological drugs, even in remote area. Sometimes you don't get carbitocin, you don't get carbopost, you don't get even oxytocin storage. All those issues will be there. And many times healthcare workers, there is absent skills to manage PPH at the initial stage. So that leads to complications. And of course, the neglecting the golden hour. So directly I go to study. So it's a novel, effective, simple and minimally invasive surgical procedure for avoiding excess blood loss in PPH in a patient in whom medical treatment fails. So the advantage of this paracervical clamp is, one is timely intervention, avoid cystectomy, then consumption coagulopathy, then thereby preserve the reproductive potential. It can be used in any settings with or without fragility, and it can be used as a prophylactic as well as therapeutic, especially patients who are high risk. In those patients you can apply and have a nice sleep. And of course it's a very inexpensive, accessible and easy to use by anybody. And it can be used both in atonic as well as traumatic PPH. And very important, as a temporary measure to shift the patient from the periphery to center, so that you can minimize the blood loss. So here instruments required are very, very limited, very simple. Already they are available in the labor room. 2 speculums, 2 sponge holding forceps and 2 paracervical clamp. If you don't have paracervical clamp, even the ring forceps or sponge holders can be used. So we should have 4 sponge holders. See, basis of this method is, so when you do routine vaginal hysterectomy for prolapse or undescended uterus, when you apply the first clamp, and sometimes if you advance it a little bit, invariably you come across the uterine arteries, or even at least descending uterine artery. So that made me to think, so this can be applied in postpartum after delivery, where cervix is very much accessible and uterines are very much accessible from below. So the uterine artery, they represent 90% of the blood supply to the uterus. So these were the clamp. You can see these are just modification of the intestinal clamp. It doesn't have any catch, and serrations are very atraumatic, and 2 speculums. So after delivery, so patient usually after active management of third stage labor and management of medical methods once fails, then patient should be taken to just lithotomy position, then explore the cervix, any tears or any laceration you try to identify, then you can suture it later. Then grasp the anterior and posterior lip of the cervix, because cervix is very long, enlarged, and so to occlude the right uterine artery, so cervix should be pulled to opposite side and apply the paracervical clamp as high as possible and as close to uterus, so that you will not include the ureter. So initial cases we applied and we checked the by ultrasound any occlusion of the ureter. So that usually very, very rare. And even if you include the ureter, nothing will happen. You are going to keep it for 6 to 8 hours, and it is a temporary occlusion. By the time hemostasis will achieve and bleeding will stop. So the clamps can fold vagina back on the uterine arteries. So the procedure is repeated on opposite side, and any cervical tear laceration, you can suture it at the same sitting, and the The sponge holders apply to anterior and posterior loop. You can remove it and keep the clamp for 6 to 8 hours. And believe me, immediately you will come to know bleeding stops or not. If bleeding stops, you keep the clamps for 6 to 8 hours. If bleeding doesn't stop, then you go ahead with the next surgical intervention. So these clamps are atraumatic, and you are going to lock it only one lock. So this is just a diagrammatic representation of the location of the uterine vessels before childbirth. You can see the common iliac artery, external, internal, then branch from uterine artery. It runs oblique and upwards. So once uterus emptied after delivery, the uterine course will become transverse, and they are very much accessible from the below, from the posterior fornixes, so that we can very much accessible from below. So this is site of application of paracervical clamp. So 2 paracervical clamp applied on either side. The proper application is very, very important. So when you apply it, these 2 clamps should a little bit crisscross each other, and they should become taut. So that's the proper application. Otherwise, if the clamps are loosely hanging, then it's not a proper application. You just remove it and reapply it. So in our institute department, everybody is trained, even postgraduate students and all the staffs. And as an initial method, after failing medical treatment, we apply it. So this is just video. So this is a simple tray, 2 speculum and 2 sponge holders and 2 clamps. So sometimes cervix should be very ragged. Anterior, sometimes you can apply the anterior and posterior towards one side, so that easily you can apply the clamp easily. So as high as possible and close to paracervical tissue. Then remove the anterior and posterior sponge holders. So you can see just they crisscross each other, they are stout. And this to show that only one lock, so that it doesn't traumatize the cervical tissue. So this actually we started using this more than 20 years. But we started documenting from the last 10 to 12 years. And so from January 2014 to 2023, so total we have 2,656 patients of PPH, and total deliveries in these 10 years around 1,25,143. So these were the year-wise total number of deliveries and total number of maternal deaths and total number of deaths due to PPH. So as you know, is a tertiary care center and one of the oldest medical college in the North Karnataka. We drain almost 7 to 8 district hospital to our centers, and many patients they will come very late, and most of the deaths are these are all all bad referrals. Our booked cases are only in single digits. So if you see from 2014 onwards, the deaths were still very, very high, and when we started using this method. From 2014 onwards, you can see the number of deaths due to PPH, it has come single digit. So definitely is, and believe me, is more, it will be 95% will be effective as an initial method. And majority of women are in the reproductive age between 25 to 30 years, and around 30% are primary and around 70% are multi. And 62% following normal delivery, PPH, and 28% following cesarean section, and 10% instrumental delivery because it's a teaching institute, and we apply a lot of forceps and venous delivery. And majority are atonic PPH, and few are traumatic, and 6 cases were broad ligament hematoma. So out of 2,656 patients, so we applied clamp in 1,144 and remaining medical method as successful. So around 43% we applied the clamp, and the clamp was successful almost 95%, and 5% there is a failure. In those cases, those patients will be taken for some surgical intervention, either conservative or hysterectomy. And 13 deaths we come across in this series. So initially all cases of PPH managed medically, and out of 2,656, 111 applied clamp, except patients who are hemodynamically unstable. So those patients will be directly taken for surgical intervention. We didn't try any paracervical clamp. So primary, so 19 patients were clamp failed, and out of 19, 7 women they ended with hysterectomy, and multigravida on 29 patients, and 13 they ended with hysterectomy, and remaining we managed with internal iliac ligation and other B-Lynch and other procedures, and 13 deaths we come across. So out of 48 cases of failed cervical clamp, so 19 patients were primary, underwent B-Lynch and internal iliac ligation, and 7 patients underwent subtotal hysterectomy, and out of 29 multi, they underwent, 12 patients underwent subtotal peripartum hysterectomy, and remaining other internal iliac ligation and B-Lynch, and mainly here severe anemia and severe PH. So these were the major risk factors associated with all these PPH patients. And 13 patients succumbed to death due to DIC and multi-organ dysfunctions. The reason for failure of these cases, in few cases we come across improper application, because most of in our institute, the postgraduates, they apply at the first step. And in my private setup, so we have a 30 to 35 delivery in a month. And believe me, from the past 10 years, I have not intervened any surgical intervention. All the PPH happened in a private setup because I personally apply, and all are successful. And before 10 years, I used to do lot of internal iliac peripartum hysterectomy in all the Hubli other hospitals. But now everybody started applying, and hardly surgical interventions are done in Hubli and Dharwad. And so that is so to conclude, so is a very important procedure, and hemorrhage is the leading cause of admission to intensive care and preventable cause of maternal mortality. So an efficient management by application of paracervical clamp can significantly reduce the need for surgical intervention in managing PPH. And the limitations in this study, initially we could not quantify the exact amount of blood loss, but later we started using a brass weight drape. And there is an overlap between medical method and of course clamp, and you cannot do study alone as a clamp, you cannot take a risk. But definitely once medical treatment fail, so before going for any temporary measures or any surgical intervention, 95% you can avoid going for surgical intervention with simple paracervical clamp. So is a treatment option in the management of mild to moderate PPH at initial stage, or next to medical management in all settings, especially in low resource countries and inadequate staff. Even you can train the nursing staff to apply the clamp, and it can be done. So I'm coming to the second part. So this is a very, very important, as we discussed since morning. So ultimately, after internal iliac ligation, after peripartum hysterectomy, still some patients continue to bleed, and they'll go in coagulation failure. And we pray God, and we'll leave the hope, or else you give FFP, cryoprecipitate, and even factor 7 will give. Some patient may survive and some patient may lose. But now, as you know, this pelvic packing and abdominal packing is an old method. And if you read the textbook of PPH by B. Lynch, so he beautifully is explained as a roll of pelvic packing after hysterectomy. And the disadvantage with that old technique is when you put the clamp and close the abdomen, after 72 hours you have to remove, and again you have to do re-laparotomy, and chance of infections very, very high. To avoid that, we modified, and many surgeons all over the world, they have modified the technique and avoiding re-laparotomy. So our institute, we modified it, and definitely is a very good procedure. Again, it can be done in all settings. And the aim is to know the effectiveness, safety of this pelvic packing and the polytamponade women when pharmacological and other surgical methods fail to control bleeding. So it's a retrospective observation study in a tertiary hospital, KIMS Hubli, from 2017 onwards. We started documenting all these cases. So patching technique was performed in patients with refractory bleeding that was difficult to control, particularly patients with coagulation disorder. So once we do PTINR, when patient is in DIC, always we hesitate to intervene again. And again it's very painful. But such cases are commonly associated with impaired placental implantation. So as placental abruption, placenta accreta, placenta previa, and fetal death. So these are the PPH patient where the maternal mortality is very, very high. So you should be very, very careful in such case patient. So from the past 20 years, the damage control surgery has been developed to manage hemorrhage and is performed in 3 stages. So one is initial laparotomy, second is resuscitation phase, and definitive surgery after all this peripherotom hysterectomy. So pelvic packing is typically used as a part of surgical phase and is a clinical option after hysterectomy and in the presence of coagulopathy. So this is a scenario most of the patients after medical treatment, after paracervical clamp, even after surgery. So once hemorrhage continues, then we end up with emergency peripartum hysterectomy. Then still the bleeding continues. Unless you keep the drain, then you will come to know. Otherwise, many times the bleeding continue internal and will not, do ultrasound, you will not confirm it, and patient will succumb to death. So this is a scenario usually happens. So here, when the active bleeding is persist, then exacerbated secondary coagulopathy sets. So it is resistant to all the methods. So such patient usually they are all hypothermic, and once metabolic acidosis sets, and it is very difficult to survive such patients. So this is when the concept of pelvic packing and Polish tamponade comes in the picture. So this pelvic packing does, so it causes on the pelvic floor most of this bleeding after hysterectomy. So this is at the base of the pelvis or broad ligament, where there will be venous sinuses, venous plexus, they start oozing. It's not active arterial bleed, and it will be continuous ooze. And some of the area they are not accessible underneath the pelvis, a lateral wall of the pelvis, obturator fossa, and so there's a lot of raw surface. So they start oozing because of ongoing the coagulation failure. So it offers a physical tamponade effect and compresses the bleeding area against the bony and facial structure. So in addition to pelvic pressure packing, and there is a Polish tamponade. So that acts as a pressure on the pelvic packing, and also it is compresses the pelvis. So this is the old technique. They used to keep a mop and they used to remove it, mushroom packing or parachute packing and all. And initially later they modified by keeping a mop and making a hole, and you can pack the pelvis, then bring the catheter outside, give a traction. So then next, so these were the other modification given in again B. Lynch books. So this is nothing but X-ray cassette, sterile X-ray cassette bag you have to take, and you have to use a gauze or a roller mop inside, and you have to keep it inside that body and head. It compresses the pelvis, and end you have to bring it and tie it with a IV tubing, and you can keep a drain so that the ongoing bleeding will come to know. Then what we modified here to simplify still more. So what we used a roller gauze tip 2 or 3, and we sutured one end to the other end so that removal will become easy. So we will not seal the vaginal vault. After doing hysterectomy, you have to take a roller gauze soaked with betadine gauze, start packing from the base of the pelvis, all inaccessible area, and that initial end should be brought to the vaginal opening, seal. So you are not going to close the vaginal vault completely. So you can keep 1 or 2 finger open, angle you secure it, and you started packing all inaccessible area, and the whole pelvis should be packed. You may require a long gauze, maybe 2 to 3. Then over that Polish catheter, they pass through the vaginal vault. Around number 18, around 4 to 5 Polish catheter. Then you inflate with 50 ml of normal saline and keep this inflated bulb over the pack and bring them to the vaginal outlet, and they can fix it to the thigh so that you can give traction and compression. And this Polish bulb, they have two functions. One is the compresses, traction, and they also act as a drain. If there is ongoing bleeding, then there will be bleeding, you can see through the Polish catheter. So this is the final picture what you get. So totally pelvis is packed, and over that the Polish bulb, so around 4 to 5 over the pack. And this is the final picture. You can see all 4 Polish catheter, and you can keep it for 48 to 72 hours. Then remove one catheter, you remove the pack. Roller gauge is easy. You don't anticipate any difficulty here. And then you remove deflate the bulb, then remove one by one. Then you keep it one. Any ongoing bleeding you will come to know later. Then you can give traction with 1 kg, whatever the 1000 ml of normal saline to the end, and just like orthopedic people, they apply traction so that the traction will help in arresting the bleeding. So after 36-48 hours, we can remove it. So this procedure, pelvic packing Polish tamponade, is a low cost method and is affordable material and available in most of the hospitals. You can do it. And this method provides a surgical team with an important treatment alternative and as a other treatment of coagulation failure, and is a life-saving opportunity when other surgical and pharmacological method fails. So for the present study, data was collected from medical records, and here age of the patient, diagnosis, blood loss, coagulation profile, number of blood and transfused, and post-operative morbidity, mortality, and ICU stay, all these were tabulated. From 2017 onwards, we come across 16 patients we come across, because in between I went to administration side and I could attend a few emergencies, and actually these patients were 2 years actual statistics. Actually, in fact, is more number. So whatever the initial study, I have taken it. And most of the patients are delivered in our KIMS, and those are referred from outside in a moribund stage. And so these were the case summary of all these patients. If you see most of the patients, they are all adherent placenta and multi, previous section, 1 section, 2 section. So these are the high risk factors where the hysterectomy doesn't help in such cases. So to summarize, so the total 8 adherent placenta and 9 previous LSS, 1 LSS, 2 LSS, and 7 atonic PPH, and 1 patient molar pregnancy. Previous to section, she had 18 to 20 weeks molar pregnancy, and while doing section, there was a perforation, and ultimately ended with bleeding. Then hysterectomy done. Following hysterectomy, she continued to have bleeding. Then we did this procedure. And also 1 patient have secondary PPH after 24 hours with infection was the cause for PPH. And after hysterectomy, the bleeding was continuous. So 7 patients underwent cesarean hysterectomy and 9 laparotomy, either following cesarean or following normal delivery. So they ended with clamp. So these were the parameters. You can see coagulation profile was deranged in all 14 patients out of 16, except 2 patients. 14 patients were deranged PTI-NR, and we gave multiple blood transfusion, ICU stay, and so actually otherwise these patients, if you left, they would have died, and only few might have survived. But with this technique, all out of 14 patients they survived. Only 2 patients we have lost. So out of 16 patients, 14 deranged coagulation profile, and so 2 maternal mortality in out of 16 patients. So 1 was acute renal injury, AKI, following the atonic all PPH, sepsis and all. Second one was AFL, acute fatty liver pregnancy. These 2 patients we could not make them survive. So in this study, 1 patient developed sepsis and AKI, they recovered, and 2 patients developed bronchopneumonia because of ventilator associated. They all managed conservatively and they survived. To summarize, the present study demonstrated the pelvic packing with Polish tamponade should be a part of armamentarium available in the obstetrician whenever intractable pelvic hemorrhage is encountered, especially in patients who undergone peripartum hysterectomy and are in DIC. So it's quite simple and quick to perform and requires no special medical materials. The rate of complication is very low and the success rate is high. So this is our second part of the study, and please do this procedure and don't leave the woman of losing hopes. We have done everything, you have done internal ligation, you have done hysterectomy, nothing can be done by giving FFE, cryoprecipitate. So many times it will not be helpful unless you make a day and try this method, even if patient are in DIC. And this is not only our study, even you go to the literature. So many survival chances are increasing with this technique. And you can avoid reopening, re-laparotomy. And definitely sepsis is not a big problem nowadays with all modern ICU care. So it needs all very good ICU care. And believe me, all PPH patient we should remember. So early identification, diagnosis is very, very important. And many times we don't diagnose early. And hypovolemia, many times we tend to neglect hypovolemia. So a simple rule is whenever patient 1 ml of blood loss, so we should give 3 times, 4 times the crystalloids. So immediate replacement of crystalloids is very, very important. So hypovolemia correction is very, very important. Otherwise, at the end, you cannot do much. Otherwise, once the metabolic acidosis sets hypothermia, then it will aggravate DIC, then it will not be under our control. So always be aggressive. And believe me, in our institute, most of the staff from, we have more than 22 staffs, from assistant professor to professor, everybody is trained in internal iliac ligation. And everywhere we do workshop for all postgraduate, even for undergraduate also, the PPH workshop. And this is very, very important. And still in south, Karnataka is doing bad, especially the northern part, the Maharashtra side. All these districts are still, I don't know, the many social factors. Social factors, they play a very important role in PIH. So PIH is the most leading factor in our area, anemia and PIH. And if you go coastal side, hardly we find a PIH patient and anemia patient. And this is especially 8 to 10 districts of North Karnataka, we are unable to control still maternal death due to all these PIH related complications, mainly eclampsia and all these medical problems. Nowadays, these maternal deaths are contributed to medical disorders, heart disease and hypertensive disease and sepsis. So these were leading causes. And of course, PPH actually in our institute, we have controlled almost near. And so this is our experience in our institute. Hope this will be very, very useful to our postgraduates also. And you start practicing it at initial step only, paracervical clamp will be helpful. And 95% will be helpful. And 5% it fails. And even after that, other conservative surgery will help. Even patient is bad, the second method, please try this and it will be very, very useful and many patient mothers can be saved. So with this, once again, I thank you all the organizing committee of Solapur Society for giving me this opportunity to share our practical experience. Thank you once again.
Thank you, sir, for the excellent talk. The demonstration of application of paracervical clamp, it was very nice demonstration and we felt that it can be done by anyone without any prior experience or without any prior training. The other method of pelvic pressure packing with Foley's tamponade is definitely useful, and as you rightly said, no woman should die of PPH. Your own innovations will definitely help in to reduce the maternal mortality. Thank you for that.
Thank you, sir.
Sir, where I will get that paracervical clamp? Hello. From where I get that paracervical clamp?
Where is available?
Available.
Yeah, actually I told, actually I wanted to patent it, but initial days I didn't know that I published it. So once you publish it, then you cannot patent it. But anyway, I applied, at least they can give a number. And already is available. In I think a recent conference you might have attended a few companies already they have come with paracervical clamp, and already more than 2 years is over. No, is not my property. So it's a public property, and they are available. And if they are not available, you can use the sponge holders. So they are effective. So 2 sponge holders to anterior and posterior lip, and 2 sponge holders you can use as a paracervical clamp, and it will be equally effective.
Okay, thank you, sir.
Yeah, the same thing I modified it, sir. But it is, a little bit angulated it. I made a serration transverse instead of vertical, and it is a soft compression. So per possibility soon will be made available. Most of the already 2 to 3 companies they are manufacturing, even they are already modified. Even they itself they are modified, company people. So anyway, is helping mothers, so it doesn't matter. And so you can use that initial method. Believe me, it's very, very useful. And 95% if you apply proper, it will be useful.
One thing, sir, these cervical clamps are not having catches.
Yeah, man.
Then
no, it has catches, and you should do only one lock.
One lock.
One lock.
Okay, okay. That's what I was.
Yeah.
And one more thing, you do you introduce all the Foley's catheter at a time first and then inflate?
Which one?
Foley's
Tamponade.
Tamponade.
Yeah, yeah. Tamponade, this, when you seal the vaginal vault, so you insert the Polish catheter from above down. So that one end is urine end, other one is inflating end. So with you take a artery and push it, it will go easily. It will bend and it will go. So you should not insert from below. Chance of infections are high. So you can insert it from above down. Then you inflate it from below. You ask a assistant. And there is a video actually, I could not show it.
Hello. Those, Dr. Ram,
Yes, madam.
those Foley's catheter, there is a mob around it, no? Mob around.
Yeah, madam. No, the whole pelvis will be packed with the roller gauze.
Oh,
roller gauze betadine, soaked with betadine. The whole pelvis is packed with the roller gauze. So this is just you can see at the end.
So just keep in mind the number of knots that we applied.
So they are inflating from below.
When to remove paracervical clamp after?
Once the initial medical method fails, then you can apply the clamp. Madam, 6 to 8 hours you can keep it. But within immediately will come to bleeding stops or not. So half an hour you can observe, and if it helps, you keep it. Otherwise, you remove it. That's all. So this is a roller gauze. So there is in between some discontinuity. Yeah, we are connected IV fluid by giving traction. Because especially placenta increta percreta is a horrible, I don't know, because many people might have anticipated the tissue, especially if is placenta involves, placenta accreta invades bladder and the parametrium and to the bladder, the tissue is so friable and however you take stitch, however you do internal ligation, it will not help. And ultimately you have to do total hysterectomy only with the difficulty. And bladder opening is a rule actually, you should open it better. Deliberate hysterectomy is better, so that you can identify the edges, you can separate the bladder, and you will be careful not to include the ureter. So that's why in all this peripartum hysterectomy for PAS, so deliberately you open the bladder, is safe. And in our personal experience, we have not called any urologist or surgeon, anybody. Yeah, we manage because you cannot expect they come easily. And only if you injure the ureter, then probably you should call. That if it's lower ureter, doesn't matter, you can implant it. But it is not lower and middle end, you have to do anastomosis and all. But legal purpose also, so better to call urologist. Only ureteric injury. Otherwise, bladder injury is nothing. You should be very well versed with opening and closing. Doesn't matter as a gynecologist.
Actually, our experience in the department, paracervical clamp is really helpful. You can save many lives, and you did not go to laparotomy. Lots of patients have been prevented, because from the day he started, all of us are using. Even the PGs are trained, they do it. And it's very easy also, that clamp we have in the department, so it's very good. Even this pelvic packing, I think 10 days back, that patient, one percreta, it had invaded the bladder. It was so horribly bleeding, and patient went home fine, without any complication. That patient, which you did she was young.
In our department, you don't differentiate this unit and that unit. So I will attend any time, any night, any unit.
It's all team
so that's how you can reduce the metal. Otherwise, it's really very painful to attend all these inquiry at the DC level, at the government level. It's very painful.
No, that patient
and
would
still,
have died 10 days back. That
yeah.
patient would have died
Yeah,
otherwise.
sir.
Because he came, he did all that and packed it, the patient was saved. Yeah. Thank you.
On behalf of all the audience, I can say Jai Shri Ram.
Thank you, sir.
I would like to invite our Ghate madam to felicitate Dr. Ramlingappa sir.
Clamps. Next time he'll come with the paracervical clamp.
Now we move on to next lecture of this session. One more technique for PPH management. A golden hour stitch in time saves patient's life. By Dr. Karande, is consultant OBGYN laparoscopic surgeon, Vinayak Maternity Hospital and consultant OBGYN at Ashwini Sahakari Rugnalaya, Solapur. He is associated OBGYN at ARMCH Kumbhari. I request Karande sir to start his talk.
Thank you, Meena. Good afternoon, everybody. I have first thank for the organizing committee for allowing me for this presentation. So basically, everything has been covered up till now. Each and every stage, each and every complications has been covered. Now, what is left to me just to show how it is been done in the clinical practice. So that is my topic, the golden hour stitch. So usually say, there's a saying called as a stitch in time saves 9. So that is applicable in our obstetric practice also. If you take a stitch in time, it can save the patient's life also. So what is the golden hour? So it is the 1 hour in which the resuscitation surgical intervention must be initiated to ensure better outcome and to prevent deadly triad of the hemorrhagic shock. That is the hypothermia, acidosis and coagulopathy, which is the major cause for morbidity and mortality of the mother. But this golden hour cannot be categorized only 1 hour because some patient might bleed very rapidly and might deteriorate even within 15 to 30 minutes also. So we can't say that as a golden hour. So we have to categorize according to how much the patient bleeding and how much the patient is deteriorating fast. So the four T's of the postpartum hemorrhages, the most common cause is the tone. Second common cause, that is 70%. Second common cause is the 20%, that is a trauma. And others are the tissue retained placenta, invasive placenta, that is 9%, and the thrombin, that is the 1%. So if you are well acquainted to tackle this upper part tone, so 70% of the postpartum hemorrhages you can tackle. So when is the right time to take a stitch? For that you have to see two things. Rule of 30. What is this rule of 30? That is a systolic blood pressure fall by 30 millimeters of mercury over the baseline. That is very much important. And heart rate also fall by 30 beats per minute over the baseline. Respiratory goes 30 breaths per minute. Hematocrit falls 30% and urine output goes less than 30 ml per hour. This all indicates that the patient has already lost the blood 30% of our blood volume. And another thing is we can go for the shock index where the heart rate is divided by the systolic blood pressure. The normal value is 0.5 to 0.7. If it is go around to 0.9 to 1, there is acute blood loss. So before happening this, it is better to take a stitch, whether it will be a vascular stitch or a compressive stitch, whichever stitch you need to take according to the condition of the patient that is required, you have to take it. So what are the various sutures and stitches you can take? First thing is the simple local placental bed sutures that everybody might be acquainted. We take a figure of 8 sutures wherever we see the bleeding to just stop the bleeding from the placental bed. Second is the vascular occlusive sutures. That will come to later on. Third one is the compressive sutures. And last one is the combined vascular occlusive and the compressive sutures, where it blocks the vasculature and also compresses the uterus. So what about vascular occlusive sutures? So all we learn in the PGs is a systematic stepwise pelvic devascularization. So what is this actually? So this starts with first thing, when the patient is bleeding, we go for an uterine artery ligation. If the bleeding doesn't stop, then go for a utero-ovarian anastomosis ligation. And lastly, we have to do an internal iliac ligation depending upon the patient's condition, which has to be performed first or last. So uterine artery ligations, as everybody knows that, uterus maximum blood supply comes from the uterine artery, 90%, as sir has already told. So blocking the bilateral uterine arteries can reduce the blood supply to the uterus and can control the PPH in atonic PPH also. So usually there are two sites, high ligation and low ligation. So for high ligation, we just can ligate at the upper ascending part. For low ligation, if you want to tackle even the cervical branches also, we have to dissect the bladder low down and go for the low ligation. So I will just, this is for all the juniors also, PGs also, how to take an uterine artery ligation. So this is a, pointer. हाँ नहीं था एक मिनट मार पाए So you go from the lower segment, from anterior to posterior, come out posteriorly, and from the avascular area that lateral to the uterine arteries, you can guide it with the fingers also, come again piercing the broad ligament anteriorly. And just tie it. So this is most safest and easiest method that we can do, and we can repeat it on the opposite side also. Next, coming to the utero-ovarian anastomotic ligations. We all know that the uterus gets blood supply even from the ovarian arteries that comes from the infundibulum ligament and from the mesosalpinx and anastomosis with the ascending uterine artery. So if the bleeding doesn't stop with the uterine artery, we can go for the uterine ovarian anastomosis and that block that blood supply to the uterus also. So how to take this utero-ovarian anastomosis? You can see this is a round ligament, this is a fallopian tube, this is a mesosalpinx, and the anastomosis will be over here. So we have to enter just posterior to the round ligament first. Into the myometrium of the cornu and come posteriorly behind the ovarian ligament, and then take a nick of the ovarian ligament near the uterus. This avoids slipping of the sutures. And then lift up the tube and come from the mesosalpinx. Again, this can be repeated on the other side. Now coming to the important topic called the internal iliac ligation. So the principle for internal iliac ligation, it converts the pelvic arterial circulation to the venous system by significantly reducing the pulse pressure which is around 85% if bilateral ligation is done, and by reducing the pelvic blood flow by 50%, and thereby aiding the clot formation and achieving hemostasis in the postpartum hemorrhage. There are two approaches. There is the anterior approach and the posterior approach. In the anterior approach, we go between the broad ligament and the infundibulum ligament and go directly downwards vertically until you hit the external iliac artery first. In the posterior approach, it is a retroperitoneal approach. At the pelvic brim, we open the peritoneum and come from the common iliac artery to the bifurcation. So what is the difference between these two approaches? So basically it is the anatomy that is related with the ureter that you should know when you are having these two approaches. From medial to lateral side in the anterior approach, you will find the ureter in the medial fold, then the internal iliac artery, internal iliac vein, external iliac vein, and then the external iliac artery. This is the anatomic structure when you are ligating the anterior division of the internal iliac artery. And we exclude the posterior division by just ligating 3 to 4 centimeter below the common iliac, below the bifurcation of the common iliac artery. Now this is a procedure. Now this is the anterior approach. What instruments you will require for the internal iliac artery? Only 3 main instruments. One is the mixture and 2 Dever's retractor, small size Dever's retractor. So this is a round ligament over here that has been cut over here. If you don't want to cut, it's fine. This is the infundibulum pelvic ligament over here. So in between these ligament, we take a incision on the peritoneum. And dissection can be done either sharp dissection or blunt dissection. And whenever you go deep, first thing you will see will be the external iliac artery. You can even dissect with this Dever's retractor. If you just introduce it and pull it, it automatically gets dissected because it is a loose areolar fat tissue over here. See, the first structure you get, this is the external iliac artery. So this is the external iliac artery which is going anteriorly leaving the pelvis. So this is the common iliac artery and this will be the internal iliac artery. And the ureter will be in this fold. So you should not miss this because in this anterior approach the ureter will be medial to your ligation. So to see the internal iliac artery we have to dissect over here. The peritoneum. See, this is the ureter, this is the internal iliac artery which is tackled by passing the mixture from the lateral to medial side. This is mainly done because to prevent the injury to the internal iliac vein, that is posterior and lateral to it. Now this is the posterior approach where we will open the peritoneum, loose peritoneum at the sacral promontory. This is the posterior surface of the uterus, this is the infundibulum pelvic ligament. We just open medial to the infundibulum pelvic ligament at the sacral promontory and again we can do a blunt dissection over here. Now here you will see that the ureter will be lying in the lateral wall of the peritoneal fold. See, that is the ureter that is in hold with the backpass forceps. That is in the lateral wall of the peritoneal fold. Now this is the external iliac artery and again the internal iliac artery is going inside the pelvis downwards. So what we are afraid of doing internal iliac ligation, we might damage the ureter, we might accidentally ligate the external iliac artery. So if you know the proper anatomy of the pelvis, so the chances of ligating the external iliac artery and damaging the ureter is very minimal. Next, coming to the uterine compression sutures, these are mainly taken in cases of atonic PPH, placenta accreta, uterine lacerations to prevent recurrence of acute inversion where the uterus is flabby and recurrence can occur. The mainly mechanism of compression of the uterine walls against each other and closing the large sinuses in the uterine musculature. The suture material used is chromic catgut either number 2 or vicryl number 1 over a round body needle. The various sutures I have already discussed, Belin sutures, Hemon sutures, Chow square sutures. Well, while taking these sutures, we should really test before whether these sutures after taking will be effective in controlling the PPH. So in that case, what we can do, we can compress the uterus and see whether there is bleeding occurring or not. If that bleeding stops, then definitely these compressive sutures will help out, and then you can proceed with taking the compressive sutures. Now coming to the Belin sutures, it is most widely used, easy and very efficient procedure in cases of atonic PPH. The success rate is around about 90%. So how it is done? There are various points of entry and exit. So this is the A point. You enter from the lower segment of the incision, go inside the uterine cavity, come from B point outside, and then go over the fundus. On the posterior side, you again come inside the uterus and go transversely on the other side and come out. That is the D point, and again come on the fundus anteriorly and puncture the E point over the incision and F point over the lower incision. And then this suture is tied on the lower segment. So I will show you a video how it is taken. See, this is the first point of entry from the lower incision segment. It comes out. Then this is the second point. Then the suture material goes over the fundus posteriorly. And from the lower segment, that needle comes out into the uterine cavity at point C. So inside this uterine cavity, go on the other side 3 to 4 centimeters and come out again posteriorly. So this needle is coming out from point D, and it again overruns over the fundus and comes anteriorly, and we take 2 bites again from the at the incision level, at the upper lip and the lower lip. So this is point E, and lastly the point F. And it is tied in the lower uterine segment. The next comes the Hemon compressive suture. It is similar to Belin sutures, but it is a little bit simpler. This is what I usually practice, and the indications are similar in cases of atonic PPH. Here, either you can use a straight needle or you can make your curved needle straight and go from anterior to posterior from the lower segment. So this is piercing the lower segment from anterior to posterior side. Just bring out the sutures and tie it over the fundus. It is as simple as that. Similarly, the same suture, another suture, take and pass it anterior posteriorly and tie it on the opposite side. So after the procedure, it is just similar completion like the Belin suture, but it is more simpler and easy and way and fast method of doing it. The Cho sutures I have already discussed. I will not go into the details. So coming to the combined vascular sutures and the compressive vascular occlusive sutures and the compressive sutures. The first stitch, already Dr. P.P. Patil sir has shown that, where it compresses both the uterine arteries and the upper segment of the uterus. The second method is the Comock method, where Comock means it is a compression of the myometrium and occlusion of the uterine arteries. It is a similar stitch. And third one is the transverse lower segment B-Lynch sutures. I will come to the indications. This is again can be done in case of atonic PPH with excess amount of bleeding. You take a straight needle with 2 loops of the sutures. Go from the lower segment anterior to posterior through and through. Cut the ends. So you will have total 2 ends on the both sides. So one suture can be brought up on the fundus and directly ligated, which causes vertical compression. And the second suture with the needle pierces the broad ligament and goes posteriorly. This ligates the uterine artery at the lower end. Now coming to the main topic, the transverse B-Lynch lower segment compression suture. I have been using this regularly. I've done around about 4 to 5 cases in cases of placenta previa, and it's very helpful. The mechanism, again, it compresses the lower segment and it devascularizes the uterus by ligating, compressing both the bilateral uterine arteries. So this is just an animation to just know the points, because there are a lot of points in this. So first the suture enters from anterior posterior in the broad ligament avascular area, goes posteriorly. Then it comes inside the uterine cavity at the B point. This is at the 3 centimeters above the uterine incision. Inside the uterine cavity it passes lower down and comes again posteriorly throughout the C point. And then again we pierce the broad ligament anterior, from posterior to anterior side. We come at the D area and this suture passes like this, from the broad ligament, posterior wall coming inside the uterine cavity, and again posteriorly and broad ligament. And then it passes to the lower segment of the uterine, where it is anchored properly to prevent slippage of the suture. And similarly, this suture goes from the broad ligament on the opposite side posteriorly and comes inside the uterine cavity. And in similar manner, it goes in the opposite direction upwards and comes out posteriorly from point H. And then lastly, again it comes anteriorly from the broad ligament, and there is tying of the sutures just above the incision. So what happens is that the uterine artery is occluded at 2 levels. One, it has a lower level that takes out the blood supply that is coming from the ascending part of the uterine artery, and the upper 3 centimeters above the incision that takes from the utero-ovarian anastomosis. So there is a double compression, and it also compresses the lower segment very effectively. So this is, I feel it is very helpful in cases of placenta previa patient. So this is how actually the stitch has been taken. But difficult to understand. It is only understandable in cases of animation only. So this is the upper stitch that is coming from the broad ligament and coming posteriorly. Now you can see the amount of bleeding that is continued. This is a case of placenta previa that is undergone. Baby has been delivered out over here. And then come from the lower segment posteriorly into the broad ligament anteriorly. Then we take a nick on the lower segment And this should be a proper chunk of the lower segment to prevent slippage and tearing of the lower segment. And from here you pierce the broad ligament, go posteriorly and come again inside the lower part of the intrauterine cavity, 3 centimeters below the incision. From here you go up 3 centimeters vertically up and come out posteriorly again. And coming out, piercing the broad ligament later on. So the last stitch comes from the avascular area, just medial to the round ligament, from the broad ligament anteriorly. So we will be having 2 sutures in the upper part. So we are tying above the uterine incision. So you can see very nicely that when you pull these sutures, the lower segment compresses and the bleeding stops. And once that has been confirmed, you can close the uterine cavity and can tie up the sutures later. So you can see that they're continuously oozing from the uterine cavity lower segment. So when you pull the sutures, now you can see there is bleeding from the cavity has been controlled. Now you can close the uterine cavity and tie the sutures finally. So what are the complications of these compressive sutures? There are the rare complications that have been cited, mainly uterine necrosis, infection, subinvolution, pyometra, synecdoche, and long-term effect impairment of fertility and menstrual problems. Now I will just like to share one photo of the complication. This was a complication of Billin suture. So basically the patient presented with acute pain in the abdomen, lump in the abdomen because the uterus was enlarged in size because of pyometra and hematometra, and there was avascular necrosis of the uterus. The patient went underwent hysterectomy later on, and you can see the cut section where it was totally avascular. So can we prevent this? So this doesn't mean that seeing such complication you should not take the such sutures. So how can it be prevented? So after taking such compressive stitches, you monitor the patient post-operative very closely. The first signs of appearance of fever, the first signs of appearance of acute pain in abdomen, if these are the alarming signs, or size of the uterus has increased, or foul-smelling vaginal discharge, this is indicating that the patient is going for necrosis and sepsis. That can be confirmed either with a color Doppler scan to see the flow in the uterus, or by a contrast MRI. That gives a clear picture whether there is any residual flow in the uterus that can prevent the necrosis. If you are feeling that it is going for a necrosis, then these sutures have to be removed as early as possible. The easiest method, if you are well accustomed, do a laparoscopy and just cut the suture. It is not needed to pull through the sutures. You have to just cut the sutures. That is all required. Thank you.
Very nice demonstration of all the sutures, compressive sutures for uterus and vascular ligatures to manage the atonic PPH. I think everybody should try to learn it for the emergency atonic PPH management. Thank you.
Thank you very much.
I would like to request Ghatte madam to felicitate Dr. Karande sir.
Now we move on to our next topic, medical legal aspects of PPH management. I request Dr. Kumthekar sir to please deliver this talk. Actually, Dr. Kumthekar sir needs no introduction. He is
You can
a
skip
very
it. You can skip it. No problem.
no, sir. He is a very respected member of Solapur Society. He is backbone of Solapur Society and pride of Solapur Society. But just to complete the this, he is a consultant obstetrician, gynecologist, infertility specialist, and medical legal consultant, working since last 35 years. He is a partner in Pioneer and State-of-Art IVF Center, Navjivan Fertility and IVF Center. He is a member of Medical Legal and Ethical Committee, FOXY, past member of Medical Legal Committee.
No need, everybody knows.
Yeah, everybody knows that's true.
Thank you. Thank you, chairpersons and audience. Good afternoon, everybody. After exhaustive, intensive and informative lectures on PPH, my problem is 90% solved, because almost every speaker has given what precautions are to be taken, and these precautions, if taken, medical legal precautions are already taken, and medical legal problems can be definitely prevented. Just to complete one Raju Karande's lecture, I would like to advise, he might be oversight, he forgot, but I always insist on internal ligation, extraperitoneal dissection we should have added. That is much more faster, safer and quickest method to ligate internal iliac, which I think in the last one of the lecture I had already demonstrated and also told it, but try it, it's very simple and fastest way to approach internal iliac in a very safe way. Sorry if I have added that was not to undermine your beautiful lecture, but to just add to the flavor to the internal iliac ligation. So coming to our topic of today's medical legal aspects of PPH management. Well, there is nothing specific about medical legal aspects to be followed, or what are the medical legal implications of PPH. There are implications followed by any complication, any obstetric complication, any surgical, any medical complication. But just as multiple precautions have already been told by previous speakers, what is to be done, how should the OT be, how you should call your colleagues, how the group practice should be, how your infrastructure should be, everything has been told. Much of my problem is solved. In all my lectures, this slide is quite pretty old to audience who has seen my lectures previously. But this has been said by Voltaire nearly 400 years back and still stands true. Doctors are the men who prescribe medicines of which they know little, to cure diseases of which they know less, in human beings of whom they know nothing. This still holds true even after 400 years, and as you know, the personal variation about the treatment and everything is entirely different, and that's why we don't know the human body really well. And that's why how you treat, how the patient responds is different in each and every case, and accordingly you have to manipulate yourself, you have to adjust yourself and treat the patient to give best to the patient, but still failures are there. There are inadequacies, there are deficiencies, there are stumbling blocks where we just can't proceed, and then probably because of misunderstanding of what we do or what we try to do or our shortcomings, the patients and the relatives suffer, and they end up in charging you guilty for what happened to them, in fact, which you are not. In very few cases, you are really negligent and the patient suffers and then you pay for it later on. Let us consider in quick succession the potential areas of litigation in case. This pertains to all medical complications. I just devised them. Yeah, I had very little time to prepare this presentation, in fact, because I just came back. But well, I prepared it, and there may be some shortcomings which I'll discuss live only. The potential areas of litigation are outcome for the patient, whether it is death, whether it's a sorry for the spelling mistake, long-term morbidity or psychological trauma. There's a residual disability patient might suffer, general effects on health, loss of reproductive capability, secondary infertility to other causes. These specifically pertain to PPH. Since in previous lectures you have seen how that can affect the reproductive system. establishment where incident occurs, individual proprietary hospital, multi-specialty hospital or corporate hospital, these are three different scenarios and the quantum or the degree of litigation changes according to the establishment. Treating consultant and team, qualification of the consultant and his experience, qualification and quality of the team in the hospital, treatment modalities, different lines of treatment, drug usage, necessity of aggressive treatment. In different lines of treatment, I would say there are always two lines of treatment in managing any case. Even in medical management, surgical management, there are difference of opinions and different lines of management. There are schools of thought. And you might follow one school of thought. The patients will have to go on to the Google and find out the second school of thought, second line of treatment, and they start arguing with you, why did you not do this? Well, believe me, it is totally our medical profession's prerogative which line of treatment to use, which cannot be contested by the patients for why you did not do this. Neither the court will ask you why you did not do this, provided our line of management pertains to certain protocols which have been time proved, or they are pertinent, or they are as per follow guidelines given in our textbooks. Drug usage, again a controversial topic. A patient comes to OPD, the poor general practitioner gives a diclofenac injection, the patient collapses, gets hard cardiac arrest, and the whole blame goes on to the injection given by the general practitioner, which is really an innocuous injection. But this happens in practice. Necessity of aggressive treatment, well, it is a double-edged weapon. I work aggressively and the patient there is some disability created, or I don't work aggressively and there is different disability or different morbidity created, and both are contestable by the relatives so far as the Google teacher tells them. But it is all circumstantial, and we should believe in ourselves whether which way to go. And that's why always all the speakers previously which have insisted all the while call for help, and that changes the scenario. Referral necessity and timing. Whether timely referral was needed and done. Conflict of interest in referral. This I would like to emphasize. I insist on going to one certain XYZ super specialty hospital. The patients have their doctors known to them in different ABC super specialty hospital, multi-specialty hospital. So there is a dilemma. I insist on XYZ, patients insist on ABC. And then they start saying there is a conflict of interest. There is some interest on you, with you to send that XYZ. Leave it to the patient. Give them options. They want to go anywhere, they go anywhere. If you are attached to one XYZ super specialty hospitals and you assure them to manage by yourself, then you can insist, because then the patient will be a bit confident. But if the patient has already lost confidence in you, they will insist on their own choice. Well, take in writing that they don't want to go to the recommended hospital, they have their own hospital to go for, get it in writing and let them go. Then most of the responsibility vanishes. Last and most important is the billing. Almost everybody gets the fight over the billing. That is a different topic. I can talk for 30 minutes on billing disputes and medical legal aspects of financial billing and all these things. Well, we have to take preventive measures. All have been taken into consideration, except only the cases which you are competent and confident of handling, otherwise call for help, already explained by previous speakers. Except the cases wherein your establishment is adequate enough to support your management. If you don't believe that it is not sufficient, don't accept the patient. Identify the high-risk cases which are predisposed to PPH and consult the patient and relatives in details. So I always tell in my lectures to give quantity, to differentiate between quantity of work and quality of work. Days have changed. Previously, in my beginning of years, we used to tell confidently to the patient, Tula samajta ka mala samajta. The days are gone. You can't talk in that language. So spend time in talking to the patient. I always tell particularly my juniors, don't spend your energy on increasing footfall on your doorsteps, rather than try to give maximum possible to the patients who are already with you. Believe me, no patient belongs to you. Neither patients, doctors belong to patients. Both are independent entities. Don't label any patient as my patient. No patient is your patient. No patient is my patient. Patients will always choose their best way out, and you are just lost. So, no emotional attachment to the patient considering my patient, what will happen to my patient? No. And lastly, availability of essential medicines within expiry date of each and such drug. So have audit of every drug kept in your stock at every weekend. Expiry date is seen on shelf even if not used in that patient. A single ampule with expiry date on your shelf can land you in trouble. And learn to say no. This is most important. You must find out your own limit and say, no, I can't do it. No, I won't be able to do it. No, I don't want to do it. That's it. Learn to say no, which is a very harsh word in our practice. But learn to say no, yes. If I can do, yes. If I can't do, or I don't want to do, no. What are the implications of PPH? You have all seen the complications: death, disability, physical trauma, psychological trauma, possible compromise of reproductive health, and financial burden. I need not go into the details of each. So what are the actual precautions? Again, they have been told to you in deliberate. This will be a summary of what precautions you can take. Informed consent, of course. And what do you mean by informed consent? Not a signature on a blank stamp or a blank paper. See, the practice of taking signature on a blank paper is the worst possible practice. Nowadays, every patient, every relative has a smartphone which is a photo capability. You take a signature on a blank paper without your knowledge, or before you realize he can take a photograph of that, keep it in store, and can be used against you. So no signature on blank paper. First and foremost principle, no signature on blank paper. Take 2-3 signatures on blank paper for safety, keep them inside, and write whatever you want later on. No, you will be exposed in the courts of law like anything, and once you are discredited, court will never believe you. Counseling, of course, you must spend a lot of time on counseling the patient. Tell them every possibility, every benefit, every loss, every disadvantage. Now, there is always a question, shall we while talking to patient after any operation, shall we always tell about the death? Well, you need not tell that you are likely to die within this operation. It need not be so point blank. But you can indicate that there can be complications in any minor operation also. There can be anesthetic complication, there can be drug reactions. You have to tell it to the patient so that the patients are at least psychologically ready that anything can happen. You need not tell that patient maru shakto. No, that's not necessary. But you can tell in subtle words the probable or possible eventualities to every patient in soft words. Transfusion readiness with specific consent. This I am going to tell more in this thing. If predisposed, consent for operative intervention. Second opinion and necessary basic investigation. Necessary basic investigations must be done. All investigations have been told. Not all investigations are related in every patient. So even if it is placenta previa, or even if it is a previous scar, or even if some previous mishap is there, or previous obstetric complication is there, you need not subject the patient, each and every patient, to MRI. That's not what is intended by investigations. See, there is always a defensive medicine and positive defensive medicine and negative defensive medicine. Negative defensive medicine means doing all possible investigation whether needed or not. And positive defensive medicine, getting done only the necessary investigations in which, in your clinical opinion, are required for the patient. At every step, at any step you feel that an additional investigation is required, don't hesitate to get it done. But it need not be a thing that person goes and asks every patient, why are you not doing MRI for the placental location and placental whether it is accreta, percreta, or whatever it is, or previa. If the patient's relatives start suggesting you, MRI ka karun ghet nahi tumi, well, you are in a dilemma. You can explain to the patient it's not necessary, everything is fine, but then it's up to everybody's temperament what to get, and it is the temperament of the patient's relative. If they insist on, you have to go. But from our side, basic investigations must be done. Possibility of a referral to higher center if it is already a marked high risk case. If treating in higher center, explain the reason why you want to treat the patient in the higher center. It includes expected financial burden also, possible residual effects and damage. Then next precaution comes is the 24/7 readiness in your hospital to tackle such situation. Now here is a clear compartment. These days we prefer not to accept unregistered case. Fair enough. You are justified in not accepting unregistered cases because probably you are not ready to work 24/7, or maybe your establishment is not ready for 24/7 because the night staff is not there, which is not competent. You don't have qualified staff. But if 24/7 the readiness is there, you can accept unregistered cases. But the best trend is to not to accept unregistered cases because they can land up in complications. But in case of forceful admission, all these things where you can't just deny the patient, your hospital must be 24/7 ready for such eventuality. Help from colleagues or seniors is, of course, has been emphasized by previous speakers and rightfully so. Next is the documentation. Second last is the documentation, and last is the documentation. Now this is the most important of all things when you manage or you want to prevent or you want to avoid medical legal actions against you. Only documents can help you. In this regard, document must be perfect. Poor documents, poor defense. No documents, no defense. And good documents, good defense is the principle, legal principle. There is no question about it. What documentation? Now remember, scanty documentation is dangerous. While excessive documentation is equally dangerous. I will emphasize on this point because other points are covered. I will explain what is excessive documentation. When a patient is coming to a patient in a collapsed condition, or when the patient collapses, there is obstetric collapse in front of you. And then in your notes, there are notes of 8:01 p.m., 8:02 p.m., 8:03 p.m., 8:04 p.m. Well, the court will ask you, what were you doing? You were writing or you were treating the patient. So what is to be documented is to be documented the major events. Now, I know that just few days back we had extensive medical legal CME which I missed because of my absence in India. But I saw it on YouTube later on. That is a good movement by our society to post all deliberations on YouTube. So you can retrospectively, you can go and see them. But a lot of things were already told, and almost 100% of our medical fraternity is now medical legally aware of what is to be done out of the way. But still, a person like me gets phone almost every other day. Even in US at 2 to 3 a.m., I used to get a phone, sir, abhi kya karu, abhi kya karu. It's okay, I answer them without any getting irritated because I know the person is in trouble. But that's what happens, still continues, it is there. But that's okay, but documentation, why excessive documentation is detrimental? The court may doubt your documentation. It may label it as a fabricated documentation. And once the doubt is raised by the opposite party or in the minds of the judges, the whole thing goes against you. So what are the likely legal actions against you? Well, police complaint. This is the one thing which are most dreaded of. We don't want the police to be involved. So what is the solution for it? We don't have a solution. So far as the relatives are concerned, their mentality, their psychology is concerned, we really don't have a solution for police complaint. So what is a preemptive action you can take for police complaint? The moment the things deviate, the moment patient becomes very serious or dies or is likely to die, get a medical legal case registered with the police. You yourself register the case. That is absolutely preemptive action because you are aware that something bad is going to happen and there can be legal implications to this mishap. You yourself register a case with the police and you have won half the battle because you yourself are aware that something is going wrong. Instead of telling जाओ कुछ क्या कर दे, क्या करो, तो patient go to the police station, sit there in front of the police PI and insist upon registering a police complaint, blaming and giving you blemishes of all kinds, which you just really can't apprehend and you get depressed of that. But especially in case of death, register a case, unless you are 100% sure of cause of death. In what sense? The patient has already come in bad shape with you. Patient is in DIC, has been shifted now, particularly in tertiary centers where medical legal can be avoided and police further postmortem can be avoided. The patient is in hepatic failure. Maybe whatever the cause, and the patient is really terminal and is brought to you, you know the cause. That the patient is in DIC, the patient is in hepatic failure, the patient is in irreversible hemorrhagic shock. And you try to treat the patient, you try to bring up the patient and you fail, still you can give a cause of death. No need of medical legal registration or postmortem. You can give a cause of death, which is justified in the courts of law with the help of your documentation. That's it. Investigations and documentation. But if there is a slightest doubt in your mind that something is going wrong, or if death occurs, it is always safe on our part to register a case with police and get the medical legal postmortem done. It's for your own safety. Sentiments do not matter. Resistance of the relatives simply doesn't obstruct you from filing a case. Even before you do anything, you inform the police and sit quiet, and you tell the relatives that nothing can be done, it has to be a police action only. It is for your own safety. Criminal cases, yes, they are always there, but most of the times criminal cases cannot be filed against a doctor if something happens during the course of treatment. Because there is a legal principle called as voluntary non-fit injuria. You have seen the boxers fighting with each other, they are hitting badly to each other. Now, can one boxer go to the police and say that he has hit me? No, there is no complaint. There cannot be a complaint because he has consented to get hit. When he is entering into the boxing ring, he has allowed his opponent to hit him. That's the sport. So this is voluntary non-fit injuria, that means something harm done with consent. And this is where our informed consent matters, because when you incise a patient, you are doing harm to the patient in legal terms. You are doing it for the benefit of the patient, there's no question about it, but you are harming the patient without any doubt. But if the patient has consented for that incision, it is a voluntary non-fit injuria. You cannot be held responsible for that injury. And subsequent injuries, if they have been explained to the patient, it's a consent given to the patient that this has to be done, this will be done, this is likely to be done. Consumer case, this is the very simple. So maximum consumer cases go into the consumer court. Consumer court, they have a simple 10 rupees stamp application and simple application, and then the complaint is lodged. But we are at an advantage here, believe me. What I am trying to do is reduce your fears in your mind about the legal process. If you, majority of the times, the medical legal conference has the increased fear in mind. At the end of a conference, I have always realized that instead of answering the queries, there are more queries in the minds of the audience. But that happens after every medical legal, because basically the law is a gray area. There are a lot of gray areas in law, which can be interpreted this way or can be interpreted that way. We are helpless against that. But consumer cases are the most common, simple process, and you are in trouble. But the advantage we are having here is, it is the patient who has to prove that you are negligent. It is not the doctor who has to prove that I am not negligent. You get it, you get the sense of the difference, you get the difference between the two. The onus of proving you negligent is on the patient rather than onus of proving you innocent is not on you. Proving you negligent is on the patient. And that is the most difficult thing to do. Because of our fraternity and expert opinion and all these things, we can get a lot of leeways or escape routes from allegations against us, and that's the way the cases are filed. And most of the consumer cases, believe me, most of the consumer cases are held in favor of doctors. What you read on the various social media are the only cases where the doctor is fined, because there is a lot of pleasure society takes when a doctor is fined. That's unfortunate, but we are at the end of the receiving end of the society, and that's what happens. Civil suit is very tedious, So nobody will go into it, because if you want to file a case of 10 lakhs compensation in a civil suit, the first thing you have to do is deposit 1 lakh with the court, and the case goes on for years or decades, or maybe the next generation, second generation, third generation. So civil suit is usually not filed, but the most common is the consumer case. Well, it's not really difficult to fight in a consumer case. I know the moment you get a notice from an advocate of a patient or from a consumer court, your next week is spoiled, you don't get sleep, you are tense, and you lose your appetite and do things. But just find out a way out of it. And there are medical legal consultants who can give you a lot of consolation, and we can find out a way out of it. So you should not be afraid, but you should be ready for it, but you should not invite it. That is the crux of such medical legal conferences, to make you aware what can be done. What are our defenses in the court of law? This pertains to all cases, not only to PPH. PPH has already been extensively discussed and what is to be done, so I don't have to go into the details. Our defenses are first and foremost the accident. It is the fantastic defense we get. In a recent case, not related to PPH, but in a case from a different city, I got a call that what had happened. Maybe I'm repeating the case, but it for the knowledge of all audience. I get a call from one of the senior consultant of my age only, and what she faced is a complaint. While she started doing cesarean section, the moment she started using the cautery, the linens started burning. There were flames, and the patient suffered injuries. And the patient went into court. Nothing happened. There were absolutely superficial injuries on the scar area. It was because of the alcoholic residue or spirit residue that was there, that was entangled into the sheet, and that with the cautery spark that was there, being a quite flammable substance, it just erupted into fire, and the patient was injured. And then we started discussing. I was telling that she was very much afraid. Of course, she was very much afraid. Anybody will be afraid. But I told her to prepare, go to your advocate, because I was, even that time I was in USA. I told her to go to the advocate, prepare a defense reply and send it to me so that I can advise something. And then there were unnecessary certain escape routes provided by the appointed advocate, which was not acceptable. I told her only one thing. You take a defense of accident. I told her, I talked directly to the advocate. Madla sir, these are not the good defenses. You only take defense of accident. What happened was an accident. And believe me, the case was dismissed. Error of judgment. This is another very good defense. I thought it is an ectopic pregnancy, but it turned out to be something else. Corpus luteum hematoma. I found out to be appendicitis and ectopic pregnancy. With the latest gadgets and investigations, ultrasound and MRI, these are laparoscopy for the diagnostic laparoscopy for the matter. Such error of judgment incidence has gone down drastically, because we have got fantastic investigative modalities with us. But still, error of judgment is one of the defense we can use very frequently. Statistics and standard textbooks. If the complication is enumerated in a percentage wise, in a textbook, standard textbook. Now textbook means, I will tell you what a textbook is and what a citation is and what a journal is. Journal is individual study. It's my study of 200 cases. It is not acceptable to everybody. Journals print it, it's your study. What is textbook? If a sentence comes in a textbook, it is peer reviewed, it is based on multicentric study, like Cochrane review and all these things, based on multicentric statistics. And ultimately then they come to a conclusion that this is possibility. And that's why the sentences in the text are important, because they are held, approved by the medical knowledge in the courts of law. A sentence in this journal in a citation or in your paper is not accepted as a valid, because it's your own research, it can be biased. But when the sentence enters into a textbook, it is a peer reviewed, it has stood the test of time, and it has a fantastic validity in the court of law. So, if a textbook, standard textbook says so, or a statistics says so, it is immediately accepted by the court. Yes, this can happen, none of a doctor's fault, acquitted. Expert opinion, recently it has been practically made mandatory. It makes a lot of difference, but there are very devious and dubious ways of dismissing expert opinion, so it has lost its importance in current arguments. A good lawyer, of course, a good lawyer is necessary. And lastly, the documents, which no emphasis needed because almost every medico-legal CME importance on documentation is given. They are very important, very, very important, and never forget to document. In spite of your busy schedule, you complete the documentation well. And here I have to give again one advice which is not related to this, but it is important to all of us. And recently there was one case, if you remember, if you have read the medico-legal cases, one of the police officer insisted on handing over all the documents immediately. The doctor was wise enough. He went directly to the court and wanted relief from this demand of police. And court really summoned the police and said, you can't demand documents immediately. So, even if you are under threat, the police will say, no, we want them now, we want them now. You have a right to say no emphatically. You have 72 hours to complete the document and hand over the copies of the document, not the original documents. Keep original documents safe with you, stored at some place, not accessible by anybody except you, and provide copies to the police station, but never hand over original papers. When the court summons you with the papers, you have to hand over original papers to the court. So always keep a copy of your original papers with you for further reference. In one of a recent case, when one of my colleagues phoned me, she had performed an MTP with all innocence. She was perfectly legally perfect. In everything she was perfect. And something went wrong, matrimonial problem and all these things. And she phoned me, sir, aisa hua hai, and police are calling me. They are asking for the documents, and mere paas document nahi mil rahe. I asked her, police bulaya, court bulaya. Who has called you? She said, court has called me. Okay, I said, just go to the court. Tell the court, original documents are not with me. Court will ask you why they are not with you. You tell them, police forcibly took them away. She was not asked any further questions about the documents. And when asked police को तो ड्यूटी बदलती है. 2 साल पहले का इन्वेस्टिगेटिंग ऑफिसर, उसको मालूम नहीं डॉक्यूमेंट्स कहाँ है. So that was a really weird defense I gave her, but it saved her anyway. But this is the thing that if the police ask you documents immediately, no need. You complete your documents to your satisfaction. If necessary, take advice of medical legal consultant like me, who is good in completing the documents and advising where to put what. Once completed documents and copied, never change anything in them. If your documents are inadequate, never overwrite or scratch anything in the document or try to change it. You can add a supplementary paper and write on it the supplement added for lack of space, but never try to write in between the lines or scratch a thing and overwrite and redact a thing and overwrite on it. No, don't do this. This will amount to fabrication of the documents and court will immediately disbelieve you. So ultimately what it boils down to, all precautions said and done, mishaps can happen. Don't worry, face them, complaint against, we prepare ourselves, you prepare a good defense and relax. It takes nearly 1 or 2, 3 or maybe 4, 5 years for the case to come up. By that time you continue your own practice, never get depressed by what happened to me. मैंने तो अच्छा किया था, ऐसा क्यों हुआ मेरे साथ? सबके साथ होता है ऐसा. So don't worry, if I am today, next time it might be you. Everybody is going to face one or the other criminal case. However correct, however precautious, however meticulous he is, cases are going to be there. So wish you all best in the practice. I am thankful to OBGYN Society for giving me this opportunity to present in some medical legal aspects. Yes. Textbook which has got that IBNS accreditation, it is listed as a textbook. When it says textbook by, Dewhurst, it is a textbook. And it will not be accepted as a textbook by that international publishing agency. So if it is certified with the international publication agency, it is textbook. And textbook means it has given all the references. You know, every sentence there is a mark, and you find the reference somewhere else. And when it comes into it, it has 2, 3, 4 references. When it comes to it, is peer reviewed. So it is accepted standard. So when a book declares itself a textbook, and it is approved by the publishing agency or the international, I forgot the name of that agency, but it is approved by that agency and given a specific accreditation number, and then it becomes a textbook.
Do you also mean to say that the reference from the index journals cannot be taken as a reference from...
It is a weak defense.
Okay.
It is a weak defense. It may not be accepted because it can be a bias. It's a single person review. It's a single person opinion. Right? So it is an evidence, but it's a weak evidence.
Thank you.
Welcome.
Girish. Hello. Here.
Okay.
See, you mentioned that you first ask oneself, whether you can manage this case. In that case, you either shift before taking the case or send it to the higher center. That is very easy. See, many of us know that we can't manage this case. The question arises when a very normal case, for unexplained reasons, becomes complicated.
Yes. That is where we label it as an accident. And they say eventuality in also practice. This is eventuality in practice. This thing can go wrong anyway. And accidents are accidents after all.
No.
So that is the benefit. Defense is accident. I tried it. It was a normal case, but something went wrong. That's it.
And secondly, you gave an example about the patient asking, MRI करायची गरज आहे का वगैरे. In that case, what I think is, करून घेऊया की काय हरकत नाही.
That's what the defensive approach is, and it is not wrong to do so. It is not wrong to do so. It's at the peril of the patient. It's at the pocket of the patient. We don't mind it. I don't get you.
Who else should sign the consent other than the lady?
See, it is only the patient that matters. Consent is, so far as consent is considered, it is only the patient's consent that is considered, except if the patient is not in a state of giving consent, such as delirious or comatose, if the patient is minor, below the age of 18 years, where parents have to give a consent, or the patient is mentally insane or intoxicated. So these are the few conditions when consent can be given by others.
Raise questions in the break.
Sure. Welcome anytime.
Request one talk on how to write the paper.
How to?
Write the paper.
Oh, well, I don't write papers too much. There are people like sir and madam who write a lot of papers.
Case paper.
Oh, you mean IPD paper? Okay, I'll tell you in short. IPD paper should be neat and clean, and they should be in a chronological order. One thing. Handwriting should be legible. There should not be no redacting or no scratching or no overwriting. One thing. The condition of the patient, as you know, date, time, condition of the patient and treatment given. These have to be in perfectly legible handwriting. If a handwriting is bad, get it written by somebody and sign it. But they should be in a chronological order, in the sense, morning, evening, or morning, afternoon, evening rounds. Or if it is a post-operative, 10 minutes, 30 minutes, 50 minutes, they should be in chronological order. And they should be clearly legible, with clear instructions and status of the patient. That's it.
We only write, or somebody else can write for us?
Somebody else can write on your behalf, but you are responsible for whatever is written in it. So you have to verify and sign it.
Now it's too late for question answer. You can have a plate of your lunch and then have free talk with Kumtekar sir.
Yes, thank you.
And
Thank
sir is available 24/7 for us. One more thing I want to announce that because of shortage of time, we cannot take the panel discussion and all question answers are already discussed. But I'm very sorry for Bakul and because she had taken lot of efforts. But I want to take another CME or another clinical meeting for Bakul and we'll have separate panelist for you to question answers.
Yeah, we can do it
So,
later.
eh,
You can do it later so that Bakul will realize how much people have remembered from these deliberations.
Oh, yes, definitely we can do that. Thank you, sir.
Thank you
for
very much. Thank you
informative
for the
time.
opportunity. And
Now I
this is
request
what I always
Archana
put
and
my
Meena to
last
come on the
slide.
dais.
And I hope this person in the middle. Jara, gere punna slide.
Adishi slide.
So I hope everybody is that person who is alert in the middle is like everybody in the sitting in the audience. Thank you.
No, everybody is awake, sir. And one more announcement is there. Next Sunday, we have microwave thermal ablation of fibroid and adenomyosis in our own institute, Markandeya Sahakari Rugnalaya. Dr. Shankar Naik, he is coming all the way from Hyderabad to demonstrate live cases. There are 4 cases we are putting there at Markandeya Rugnalaya. The CME will start, live workshop will start from 8:30, 9 o'clock till 2 p.m. Pre-lunch session is there, free breakfast is there, free lunch is there, free demonstration is there. I hope you will attend.
I would like to, Ghate Madam, to felicitate Dr. Kumtekar sir. Also, I request Dr. Chairperson to join on the dais. I would like to request Dr. Ghatte Madam to felicitate Dr. Archana Shah Madam, Dr. Gunzotikar Madam. I hand over mic to Dr. Chandrakant Sadhu.
I am really thankful to all audience for patiently listening, and though there is a low glycemic level, I am very thankful to our speakers, Dr. Kasturi Madam, Dr. Ranglingapaka Sir, Dr. Patil Sir, Dr. Kumtekar Sir, Dr. Sadhna Deshmukh Madam, Dr. Jagirdar Madam, and Dr. Karande Sir, and Dr. Pekam Madam. Also thankful to our chairpersons, Dr. Jamma Madam, Dr. Magai Madam, Dr. Archana Shah Madam, and Dr. Meena Gunzotikar Madam. I am also thankful to our pharma companies, Irika Remedies, Asif and Majid, and Endobest Life Sciences Private Limited, Mr. Shirish, Farooq, Nazir, and Wasim. Thank you. All are requested to take a lunch.